I love your space, by the way.
Oh, thank you. Yeah, it's the attic of my home.
You told me this is a new home for you. Am I correct about that?
Yes, that's correct.
Well,
Yeah.
Is this your first family home or?
Yes, before this I was living with my parents.
Wow.
Right down the street. And now I built this home brand new. I designed it all myself, and then I was the general contractor on the build.
My friend, you and I have a lot in common.
Really?
More than you can possibly imagine. I have been designing and building things since I've been 5 years old.
Wow.
And I didn't design this home, but I did it was completely gutted and renovated, a brand new home. And I designed just about everything in this home, including the furniture.
Mm-hmm. And do you have a passion for architecture? Do you like nice buildings?
Yes, that was my first, well, I think the first thing I wanted to be was an astronaut. But then I wanted to be an architect for a long time. And this fascination or obsession with designing and building things is so much a part of who I am. Going back to when I was probably learning to speak. So it's so interesting, the synchronicity of your background and my own.
Yeah, totally. Another thing I noticed that could be a similarity, I was on your LinkedIn page earlier and saw that you had meditation listed as a skill. And I wanted to ask you, what's that all about?
It's a life skill. It's an essential life skill. The tuning of the mind-body system and the ability to heal from childhood traumas, traumatic events, or what's been known as adverse childhood ACE, adverse child events, and to have the resilience to withstand the stresses of life, which is so important to people in this community who have airway problems and they have a narrowed window of tolerance because of their impaired executive functioning because of obstructive sleep apnea. And so it's an essential life skill for me. It's something that I've been doing on a regular basis, as well as physically training my body now I'm in my 8th year of these practices, which are essential life practices for me.
Did you say your 8th year?
My 8th year, yes. I'm now in my 8th year of training. I'm with a world-class trainer. I'm the only person that I know that on his CV, at the end of my CV, if you look at, I think it's on my website, I put something about lifestyle and values and lifestyle. I can't remember how I expressed it. And probably the very first thing that I put was that I'm a mindfulness practitioner, and I have been involved with, I've been with the same world-class trainer for 8 years.
And who is your meditation teacher? Are they someone that's well known? Have they written books?
No, because not all people that are skilled do that. So I started off I'm 67 years of age. So when I turned 60, I was in the operating room for 24 hours a week, 12 hours a day. And it was very taxing on my body. When I'd come into the work the next day, we're really taking a deep dive on David Bell. I'm used to interviewing other people and getting to know them. So you're asking me about me. But I started off by asking about you. Yeah, so I found that I was not able to be most effective. And I distinguish between efficiency and effectiveness, right? So and there is a difference. So I noticed that there was one man in the gym. He was the head trainer at a place called Equinox. So I live in Newport Beach. Equinox is right at the intersection of Irvine and Newport Beach, or Santa Ana. in Newport Beach. And he trained people in a different way. And so he was the head trainer at their flagship location. His name is David Lee. And he has an extraordinary knowledge of biomechanics and an appreciation of the mind-body system. And just to give you an example, so he was the head trainer, and then after the pandemic, he started training in my home. I have my own gym here. But for example, I used to go in at 5 o'clock in the morning, so there was almost, and I still train at 5 o'clock in the morning. There's almost no one in the gym at that time, maybe about 8 people. And there was me, David Lee, Kobe Bryant, and his trainer, who used to be Michael Jordan's trainer, and Kobe Bryant's daughter, the one he was in the helicopter with when both of them were sadly killed, and her trainer. And that relationship between me and him has been evolving for now in its 8th year. So, and that's about the time when I started my mindfulness practice. Mm-hmm. And it's the, by the way, you can, I wanted to start off by asking you what you wanted to talk about, and also give you permission to interrupt me, because I can go very deep on any subject. And I prefer to slow subjects down to make sure that me and whoever I'm speaking with are tracking one another. And I want to make sure that you are tracking me. But that's the short answer and a little bit of a deep answer. I could go a lot deeper, but I want to keep it in with a, we could always return to this. Yeah.
Yeah. Did you have a relationship with Kobe Bryant?
I did not. Kobe Bryant was a very kind man, very friendly. Him and his family lived probably 5 miles from me. And I was always very respectful of him, so I didn't, high five him, hey Kobe, and all this other stuff.
Yeah.
A lot of people did that, but I wanted to respect his time with his trainer in the gym.
Yeah.
Yeah.
Very, very sobering to all of us what happened to him and his daughter. Do you contemplate death as part of your meditation practice?
I'm constantly aware that you and I, we all have limited resources. We have short-term resources and we have long-term resources. And I always invite my patients to consider the same thing. And short-term needs and long-term things. So one way to think about it is that we have limited time and we have limited energy in this lifetime. But I also believe in past lives and I also believe in future lives. And I know I was talking a bit about trauma and the nervous system. I know how trauma is passed down intergenerationally, and it can be healed in an intergenerational manner. So think of how many lives you've touched. By the way, I want to honor and thank your friend Akash for contacting me on Reddit. I think this is very important work that you're doing. There's another man on Reddit called Shui Kai who made some gifts. And I'm so proud to be part of this community. It's such an honor. Yeah, I do contemplate death, but I don't mull over it. I don't obsess over it. I recognize it is a part of life, and it's a natural process.
Yeah. Would you describe your metaphysical and cosmological understanding of the world as Buddhist in terms of seeing things in terms of rebirth?
Yes.
That you believe in the law of karma?
Absolutely. Absolutely. As a matter of fact, my practice manager always reminds me of this. And I would like to speak a little bit about my practice There's so many directions that we could go off in, but I am very aware that you and I are in a ecosystem, a bio-psychosocial ecosystem. And this is one of the reasons why I give my patients a bio-psychosocial questionnaire when they come into my practice, because I really want to understand their story, what their short-term needs are, what their long-term needs are, what their short-term resources, what their long-term resources, and their values. And I want to meet people where they're at. And sometimes we're a good match, and sometimes we're not. Sometimes I wish I could be all things to all people. I do offer complimentary consultations. I've had to put some boundaries on that because people wouldn't show up, or they would confirm at the last minute, and then we say yes to them. That means I'm saying no to someone else. So I do believe, as you say, in the law of karma, and there's many ways. The way I prefer to think about that is that we are in a biopsychosocial system. We are very, very small in the universe, and we're just a speck in time. And one day, you and I will be people's ancestors, and we will leave artifacts, this recording, for example, of our existence, just the way the Egyptians did, just the way the very first cavemen did. Mm-hmm. We are always, and those artifacts are part of our karmic experience, as it were. Mm-hmm. One thing, I've practiced many different types of meditation, and it's interesting that you picked up on that. You noticed that. So one thing that I practice now a lot is something called yoga nidra, which is extraordinarily powerful. And through the practice of yoga nidra, I have the state of yoga nidra becomes an embodied trait of my nervous system.
And what is yoga nidra in a nutshell, and how has it changed your daily experience?
That's a great question, man. You ask a lot of good questions. You're such a skilled interviewer.
Thank you.
You meet people where they're at. Yoga nidra has been classified as a state of non-sleep, deep rest. Physiologically, and I'm not an expert on yoga nidra by any means. I'm a practitioner of it, but we're all practitioners. That's a basic concept of yoga, the concept of beginner's mind. So the greatest basketball player in the world, for example, and the neophyte always has their edge of what they can do, sometimes known as the razor's edge. And so the practice of yoga nidra allows the mind to be fully awake, and to be in different states of consciousness, while other parts of the mind, which controls the body, are in a state of deep rest. Mm-hmm. And so with that state of deep rest, that allows one to welcome clarity, not confusion. Mm-hmm. Clarity, not ambiguity. And truly what you and I and everyone else on this planet needs, and what my patients so much need, is safety and trust. Yeah. I find that when I can trust myself, other people are able to trust me. If I can have compassion for myself, I can have compassion for others. If I can forgive myself, I can forgive others. If I can love myself, I can love others. Yeah. That's perhaps why on my Reddit profile, I'm wearing a shirt that says "Choose Love," because it's always a choice.
Mm-hmm. Mm-hmm. Yeah, the way you describe yoga nidra as a kind of very awakened and alert, silencing of the mind, quieting of the mind, perhaps, that gives you this sort of physical rejuvenation, reminds me of a different meditative concept that I've heard of and that I've practiced called samadhi or jhana, where you're quite awake and quite alert, but focused on a singular object, such as the breath in the body.
Yeah.
And it's a very powerful experience that I had the opportunity to train in for a couple of years, actually, also in Southern California, in Valley Center in San Diego County with a teacher there, which is actually ultimately what led me to become interested in the jaws, because as you put it earlier, I had a very limited, essentially I was very sensitive, but you used a phrase earlier that I'm not recalling right now, but
a window of tolerance for stress.
I have a tiny, tiny window of tolerance for stress, and I have for a long time, and that always perturbed me because it limited my ability to function, essentially, which was frustrating because I have big ambitions and I can really gobble things up. However, I've always been capped, and to some degree continue to be capped by this chronic headache condition that I've always had.
That's so interesting, because what I hear my patients say all the time, I hear them say the words, especially patients that have had medical trauma. And usually the medical trauma goes back decades, starting with the traumatic life events that causes the face to grow in a certain manner. We can dial that in a little bit later. But the window of tolerance, or as you said, you're a person that is, it seems to me, the way I've heard you say, and I should, sometimes I just literally write down people's words. You said, I think you said you were trapped, or some such word. And my patients frequently describe that they are trapped in their body, trapped in their face, psychologically and physically, especially after medical trauma where they've had bad outcomes from their surgery. And I have a lot of patients that reach out to me from around the world for revision surgery. And they use the same words, those same words. Well, remind me again what the word you used. You said, when you said that you couldn't be the person you were, that's what led you on this journey that's brought us here to this conversation. There was a specific word, but do you feel like I understood what you said?
Yes, you definitely understood what I was saying.
I just want to track that, confirm it.
I mean, to make it a little less esoteric and more tangible for audience members,
sure.
I was literally sitting meditating 4 to 8 hours a day, and getting extreme neck pain from it.
Wow. And do you understand biomechanically why that is so?
Well, I think so. And of course, speaking to people like you has helped me understand more. But the clue that led me to my understanding of the mechanics of it was that I noticed that as soon as I would come out of the meditation, I would have the neck pain. And then when I would kind of elongate my neck, the pain would ease up, but that I couldn't habituate the elongation of the neck. No matter what I did, as soon as I took my mind off my neck posture, I fell back like this, and then I would feel a nerve essentially being irritated. So I think it was, what I concluded ultimately was that my small jaws were forcing me into a certain kind of forward head posture that was straining the structures at the back of my neck, the greater, lesser, and third occipital nerves, and irritating them perpetually. And also I was waking up with headaches, which further led me to realize something bad was also happening in my sleep. So
right. So you have that's what we call an embodied sense of knowing. You knew that. No one, I always remind my patients that they are the authority on their own experience. You are the authority on your own experience and the author of your future. It's truly amazing that your story, what's led you to this conversation. So just to make it a little bit more granular, the reason why that neck pain is the body is maximized for or designed for optimal biomechanical efficiency. And so you said when I took my mind off it for a second, I reverted to that posture. So the center of mass of the cranium should be directly over the head of the humerus, which should be directly over the head of the femur. Now we're talking about from a side view, right? Which should be directly over the knee, which should be directly over the bottom of the tibia, and which is directly over the patella. Not the patella, the calcaneus. So what the body will do is sometimes literally jut the jaw forward, but obviously you can't always talk that way or function all that way. So the body develops a adaptive strategy by going like this or going like, so that's what we call it, that's an exaggerated cervical curve, which is probably the second most common pattern. The most common adaptation is what people have called military neck, where the neck, you lose the cervical curve and the neck becomes straight. I see that all the time in the radiograph.
And what does that look like? Like a chin tuck?
Well, that's a great question, because you could have that. You could have it elongated with the head backwards. I could show you examples. By the way, that GIF you see that Shuikai did, you can see the C-spine derotate in 3D and in 2D. We'll come back to it. And then the third one is actually a reverse curve. So that neck pain that you're describing, the way I like the analogy that I give to my patients is, because a very common symptom is, imagine a construction crane or something with a wrecking ball, right? Mm-hmm. So that's hanging over the end, and that cable has to pull back to prevent the whole thing from toppling over. So because your center of mass is off and your head's quite a distance from the ground, then your muscles are in constant tension to pull it back. By the way, muscles are part of a chain of muscles. There's actually chains of muscles. There was a patient whose results I posted on Reddit a while ago, who's a longstanding yoga practitioner, and she described to me that pain, the pain went all the way down to the soles of her feet, because all the muscular chain, which includes the calf muscles, the hamstrings, the glutes, the lower back, everything all the way up to the top of the chain she had a lot of flexibility, but not a lot of stability, which are reciprocal biomechanical attributes. And mobility versus stability, or flexibility versus stability, strength versus flexibility. So that's why you experience that tension, that constant neck pain. And think of it, if you're sitting in a certain position, and most people are right dominant, so they're actually, and it's made worse by the fact that most people are going to be like, go outside to a cafe anytime, you're going to see them with their phone.
Yeah.
Right?
Yep.
Is it any wonder that we're the wealthiest country in the world, but we're the most disconnected from one another and from ourselves? We're the most in debt. We're the most addicted, and we're among the most unhealthy. And speaking of time and energy, what's the one thing that pulls all this together? Oxygen. If we're not oxygenating our brain, if we have dysregulated sleep patterns, we don't get enough REM sleep. We don't get enough delta wave sleep. We are, we're not going to survive as a species.
Yeah.
I mean, it's an epidemic. It's an epidemic. And that's why there's this groundswell movement of which you are, like I said, I said to you in the email, I really believe in the work that you're doing.
Yeah. What did you mean when you said that I was a map maker?
Yeah, that's a expression a friend of mine says to me. So a map maker is a person that you are you're going into uncharted. No one's ever done what you're doing. Is there a man on this planet that is both a healthcare consumer that shares his knowledge? I don't know anyone aside from you that's doing what you're doing.
Well, for instance, I looked for videos of you online before this interview and I couldn't find a single one. So I'm certainly the first person to interview you for YouTube.
You are. And there's a very interesting story of what led you and me together. So in 2015, I had a patient come to see me who was raised by her aunt, and she came in needing and wanting orthognathic surgery. I used to work with a very large integrated healthcare system called Kaiser Permanente, and me and my partners were responsible for doing orthognathic surgery on 1.4 million patients. Wow. So I did I had all the orthognathic surgery that I could possibly want, and actually part of the reasons why I left the organization was because the quality, I couldn't keep up the quality as much as I would like to. It was extraordinary. I had unlimited time and resources, but I couldn't keep up the quality. Anyways, this woman came in and she told me that she was on a Facebook group called We Need Got Jaw Surgery. And so I went on there, and I was shocked at how little resources there were for people, how little information there was. There's a lot of bad outcomes and a lot of questions that people were asking each other for answers that they weren't getting from their surgeons. That woman, by the way, was raised by her aunt. Her mother died in prison because of heroin addiction. But she had this fascination for orthognathic surgery. And I said, you could do that. You could do that. No one ever believed in her. She would bring in these books. She said, Dr. Bell, what's this? What's this? I was honored to receive a call from her last summer. She said, Dr. Bell, I want to let you know I'm in medical school. It's because of you.
Wow.
Think of how many people you are touching. So after I left Kaiser, I was pretty inactive for a couple of years. A couple of practices in Newport Beach wanted me to join their practice, but I quickly learned that they were like basically practices that took out, teeth and put in dental implants. They weren't orthognathic surgery practices, and I wasn't really interested in that. So really, my practice only started a year ago, and I just started posting on Reddit, and all my posts began with my answer to the question. Which is I was just answering other people's questions. And then I got really, really busy, and which is why my website really is not built out very much at all, and mostly and so I wanted to educate people, try and give them resources for healthcare consumers, not only to interpret the research, but to give them the benefit of my experience and what I learned and where I was going and how I do things. So it's so interesting that my desire to give of myself and educate other people. And by the way, a big part of how I practice, I know that I only have limited amount of time I'm actually very generous with my time, but I always want people to leave with a lot of educational resources. So I point to the educational content that I put on Reddit. And indeed, your friend Akash That's what brought us together. So,
Yeah, Akash he's an amazing young man.
he thinks very highly of you, and he also thinks very, very highly of Shuikai. I mean, it's just, like I said, Ronald, I'm so proud to be a part of this, an honor to be part of this extraordinary community. It's humbling. It's really humbling.
Yeah, it's kind of an underground community of really amazing people who, and honestly, they're way smarter than I am. In particular, Akash and Shuikai are just incredible. I don't even really know much about them apart from their interest and understanding of this space and their drive to help me do better at what I do by pushing me and forcing me to ask the right questions and talk to the right people. They're sort of the unsung heroes of my channel, you could say.
That's so beautifully stated. It really is. Every member of this community is the unsung heroes of it's like the sharing of energy that I always tell my patients are my teachers, because they come to me with problems that I have to solve. As a matter of fact, so many of my patients knew about this event today, and they sent me well wishes. And one patient in particular, I called him yesterday. I said, because he's on Reddit, he's on Discord, and I said, what are they talking about? What are they curious? There's this intense curiosity and about orthognathic surgery. Like, what are people curious about? What are they confused about? What are the problems that they encounter over and over again? So just like you said, the people pushed you to be the best version of yourself. My patients do the same thing for me.
Yeah.
And it's really humbling. It's and that's an embodied sense. It like almost makes me want to cry, because that's how honored I am.
Yeah.
And those are not tears of grief; those are tears of joy.
Totally.
That's the throat is the yogic, the different chakras, the communication center, right, where we either speak express our grief or express our joy.
Mm-hmm. Mm-hmm. Yeah, that's remarkable. And in particular with me, I'm not sure if you know.
We're really taking a deep dive here, aren't we?
Well, why not, right?
Why not, exactly.
If I try to box these interviews in too much, I don't enjoy it anymore. And if I don't enjoy it, then what's the point? It's not sustainable. I strive for sustainability in what I do.
Me too. That's why I take care of myself.
Right. Yeah, me too. Me too. Yeah. Just to drive home that last point about the role that other people play in my channel.
Yeah.
I'm more of just a network than I am a talent. And what I mean by that is I'm like Facebook or something, or I'm like Reddit, where all I do is I exist as a node that other people can pass through to provide information and ask questions, because essentially I don't do any real independent research of like literature, or I don't study papers. I don't read books about this stuff. I just twice a week through my one-on-one coaching, if you can call it that, it's basically, airway patient advocacy, where I make people generally aware of the space and help them avoid some of the, minds that blow people up when they first enter into this space. My whole way of keeping up to date with the space is just doing those weekly calls, because I learn about, what was this person's experience in East Europe trying to get expansion? And what was this person's experience getting jaw surgery in Turkey? And what was this person's experience consulting with 5 American jaw surgeons about whether he should do a MARPE before he should do an MMA surgery? And just being there to hear these people out is what gives me my knowledge.
Yeah. What I hear you saying, you're an antenna. And an antenna is a receiver of information, and you're, in a sense, creating this holy space. There's you and the people with whom you communicate, and you create a quiet space for the passive information. You share what you know, and they're sharing with you. No different than me, my friend. It's no different. It's the same principles.
Yeah, that's amazing. So maybe to bring our conversation a little bit more down to earth. And what I mean by that is to tie it into some of the technical stuff that
the physical thing. Yes.
How do you feel that fixing people's faces feeds into this sort of complex existence that they have that includes the mind, that includes the body, that includes the heart?
Yeah.
What's the role of the facial structure in some of the illnesses, psycho, spiritual, physical, that people are plagued with today?
Well, to answer that question, it's important to understand that the growth of the facial skeleton has changed markedly since the Industrial Revolution. I think most people are aware of that, right?
Certainly on my channel, yeah. I mean, just last week I interviewed Sandra Khan, who wrote the book about that. So that's my second interview with her. So yes, we all accept that there's a small jaw epidemic out there. Right.
And if you had to summarize what Dr. Khan said, because I could tell you what David Bell understands, but she's probably has a deeper understanding than myself. How would she describe the multifactorial? Well, it's multifactorial, but if there is a unifying reason why that occurs, what is your understanding of that?
I mean, my 12,000 foot understanding of it is that there's some violation of natural law that's occurring when it comes to how we're using our bodies, specifically with the loads that we're putting into our jaws from a very young age. And then over a multi-generational time frame, this is feeding back as now not just an environmental, but a genetic problem as well, where we're epigenetically passing down some of these maladaptations or malformations of facial structure. So now we have an interplay of genes and environment. But to bring that down to earth with concrete examples, failure to breastfeed is, I think, something she would point to. And by the way, I'm open-minded, and I've had people on who disagree with this stuff.
Right.
But
one thing is to be sure. There is the more modern understanding of genetics is, as you have pointed out, epigenetics or genetic potential and the activation. But an easy way to think of it for the readers is that there are really no environmental demands on our body. I mean, life these days is, drinking, watching TV, right?
Yeah, like Wally's screen in front of your face in a recliner, drinking milkshakes. Yeah.
So there's no environmental demands, and our nervous systems are such that at one time we had very low novelty, punctuated by high intensity. So imagine if you were a farmer, you saw the same thing every day, right? Same field. Occasionally there would be a thunderstorm, induce a lot of fear. So low novelty, punctuated by high intensity. Now we have endless novelty with high intensity. Think video games, food, sensory events, and complex sensory events. The nervous system is not designed to handle that. The body is not designed to handle that. We have to purposely stress our bodies. So one thing is we have a cerebral cortex, which is like to make sure that we nourish ourselves, don't bump into walls and things like that. But we also have a limbic system that is very prone to, it's our fight and flight mechanism. And we also, there's something called much more primitive, that's the mammalian upgrade to the more primitive vagal system, which is what snails and so on use. So because of that, there's high amounts of stress, right? The nervous system and the immune system gets affected. And we see constantly allergies. Allergies are super common. We know that allergies are exacerbated by stress. Ask anybody that's got asthma. We get high cortisol levels, which causes hypertrophy of the tonsils and the adenoids. And people are breathing through the mouth. So the face grows downward, right? Plus, there's no tensile stresses on the bones, so we get small jaws with a downward growth pattern. So the face has changed considerably, the growth of the face, and we can talk about, you and I can talk about being in a place of quiet where we can function optimally make good decisions, function efficiently, but we cannot escape the physical reality of our existence on this planet, right? Yeah. If you don't have time, if you don't have money, you don't have energy, life is pretty challenging. If you don't have close connections with other people, you don't have emotional connections. And there's a big difference between emotional connections and support. So support is transactional. Connections are relational. Right? And they're based on emotions. And they're reciprocal, equally reciprocal rather than transactional. So life is very hard, and because of the significant change since the Industrial Revolution, the dissolution of families, migrant populations, people that are warring on each other, it's hard to function. And also, we're mammals, right? And our faces are social currency. We can't nourish ourselves. We can't oxygenate ourselves. We can't express ourselves. We can't say the words, I love you. You can't greet the world with an open heart if you're trapped in your body. And people now are starting to understand this. They're starting to understand that this is not just teeth you could bite. It's not, there's biologic value in having an attractive face. And there's a high emphasis. It's not the only thing. If I was in an Aboriginal tribe and I could build boats and we needed to get places, I would be a high value. But so where this all comes together and people are starting to understand this is that the mind-body system and the value of our face, or as I heard one person say on Reddit, our faces are social currency. And so people are starting to understand this, and they're starting to understand that the like as I tell people, an optimal surgery is going to look good, it's going to work good, it's going to provide optimal oxygenation, and it's going to be stable, it's going to be durable, and you need all four. If you only have 2 of 4, I don't consider it to be a success. Now, one can calibrate those different values, and certainly to a certain extent, depending on the skill of the surgeon and his ability to use technologies and design things, patients could be placed at risk for bad outcomes. But when practiced at the highest possible level, they are calculable based on data, and they are predictable, and it removes ambiguity and uncertainty, which goes against our basic need as described by Maslow for trust and safety. Safety and trust are especially with women. Men get angry, women are fearful. Ask your wife. Ask any woman, how many times have you feared for your life?
Yeah.
Ask women what they feel in traffic when somebody cuts them off.
Oh, my wife got road raged the other day by some person in a pickup truck who stopped in front of her. He was riding her tail, and then she pulled over to let him pass, and then he pulled in front of her and stopped his vehicle and started yelling at her and almost came out of the vehicle to attack her. And she froze up. And this is a Navy veteran who's a pretty tough cookie. But when push came to shove, she froze up and feared for her life.
That's a vagal shutdown. So that's our most primitive response. That's what snails do. All the blood gets shut to the lungs and the heart. Don't move. There's a shark coming by. That's why people freeze when they see a bear or a shark. Right. It's a protective mechanism. So there's been four responses: two from the sympathetic nervous system, fight or flight, and from the parasympathetic system, freeze and fawn. Fawning is, Ron might say something nasty to me, so I'm going to butter him up and be nice to him. So I'm fawning.
Right.
She must have been terrified.
Yeah, she was.
She was frozen in fear, quite literally frozen in fear.
Correct. Yeah, correct. But to your point about maybe women and men differing slightly in general when it comes to some of the core psychological things that drive them. But you're talking about people's feelings and sort of approach to working with a jaw surgeon, planning for a jaw surgery, and some of the things that come up in that process. Is that right?
Yes, because if you were to ask me, David, how does a person find a good jaw surgeon, right? The answer is always going to be, well, what does that person need? And the first thing, the primary thing they need is to be able to trust that person. If I say to someone, I'm going to cut your upper jaw into 3 pieces and your lower jaw into 5 pieces, that person needs to be able to trust me. Trust that I can do what I say I'm going to do. Trust that if something unexpected happens, I identify it, point it out, and provide a solution rather than neglecting it, dismissing it, gaslighting the person, and then finally abandoning them, which is what I see sadly a lot. So trust is a huge thing. Yeah. And the one thing that some people, sadly, I will never gain their trust because there's too many traumatic things in their life. And different people are required different things to trust a surgeon. So some people need a lot of information. I'm sort of wired like that. I need a lot of information to remove ambiguity, to remove uncertainty, to understand what my options are, because we all have, for every surgery, for anything in life, indeed, there's options, risks, and benefits, right? So how does one establish trust? Well, we all have different love languages, right? And so my love languages are words of affirmation and time. That's because I didn't get a lot of those as a child. So I try and give people my time and my attention, attunement to their needs, whatever their needs are, and I try and meet people where they are. What are some of the other things that are? I also, I do that by giving people free consultations, a half an hour. I don't offer a lot of them, so I have to put boundaries on them. But I do this, right, just to establish rapport. I give people a document that says 8 questions to ask your surgeon. The questions that they don't think of. So one thing that I invite or offer people is, would you like to speak with someone I've operated on that is the same age as you? the same sex as you, had the same facial deformity or abnormality as you? Would you like to speak with them? And interestingly, a community of patients has grows. It's very organic growth, right? I give people examples like before and after, these, and I always try and illustrate what I'm talking about by real examples, like before and after results, not just words and hand waving, because that can be very ambiguous and uncertain. Some people are not visual. Some people can visualize things. They've got well-developed occipital cortexes. Some people don't. So I ask people to ask the surgeon, what kind of technologies do you use? Can you quote me your statistics on different complications? I know because I've got an Excel spreadsheet with thousands of cases on it for any given thing that is less than ideal. Because it's not enough to say there's complications. You have to talk about what are those complications and what is the probability of those complications. There is a huge difference between having an early low-grade infection after surgery, which usually presents 3 to 5 days after surgery and quickly resolves, and needing revision surgery. Yeah. If you need revision surgery, it's only, in my hands, it's only 1.5%. If it happens to you, it's 100% it happened to you. But there is a huge difference, and these are the kind of things that people really require, and time, attention. There's so many things. You said something before that I don't really think of it the way I like. We all have different wisdoms. You have wisdoms that I don't have. You're a married man and you have a child. I don't know anything about that. I was married at one time. I was divorced 4 or 5 years ago. I never had a child. I love being around children, and I have a very open heart. But I've never been in a place where I could really feel that I could fairly raise a child. So we all have different wisdoms, and I try and share my experience, my personal experience, and my story. I also choose to lead with vulnerability, describe my own childhood traumas and my adult traumas, and how I've healed from those traumas. And so those open gaping wounds are now just scars that gives me resilience. I notice that my patients do the same thing when they put posts on Reddit, and I remind them that how many people they've touched, where they've talked about their own experience, what led them up to surgery, what happened after surgery, and their challenges and victories after surgery. Because healing of the mind-body system is different for everybody. Yeah. It truly is. And you described it very well yourself.
Yeah. How so? Earlier, you mean? Or is it something?
Yeah. You said that you were a mindfulness practitioner.
Oh, yes.
And you noticed that you had neck pain, right? And you described, I don't know what medical procedures you have had or not had, whether you have ongoing challenges, either attentional or physical or emotional or financial. I don't know. We're so complex and we're so the same.
Yeah.
We really are.
What I'm hearing from you is a really comprehensive approach to understanding and treating jaw surgery patients, which is unusual. And I think, first of all, I think there's a huge fascination in jaw surgeon personality typing, and people want to know about who their surgeon is personally and what he's like. I think that you guys are on a pedestal for sure, and not necessarily in a negative way, but people look up to you as sort of larger than life figures just in virtue of what you do. You rebuild faces, and that's special. And I think you definitely present differently than other jaw surgeons I've communicated with. And I think that's very interesting. Have you noticed, would you like to comment on that? And what have you noticed generally about what jaw surgeons are like on average, or what type of people are drawn to this profession?
Well, I can comment on that. I want to differentiate between being judgmental and being discerning. Okay, there's a huge difference, because everybody's story and everybody's feeling and everybody's the way they present themselves and the way they are makes sense given their history. So what I've noticed is that my practice is very different from other practices. Okay.
Tell us about that as part of the other thing that you were explaining.
Yeah. So we were talking about time and energy before. That was a theme that was brought up. And so I have a very low quantity. There's always a reciprocal relationship between quantity and quality. So let's take McDonald's, for example. McDonald's is a high volume, low profit margin, rapid preparation time, and low quality product. And it fits the needs for a certain consumer, right? There are there's not that many expert orthognathic surgeons on the planet, as you know, right? And I have a very low volume, high intensity practice by its, you really can't do, or I can't do more than 100 cases a year. That would be the absolute most, because for every hour that I spend in the operating room, like just even in planning, it takes me at least 3 hours to plan, if not 4.
Now, if I could just pause very briefly to open that up a little bit.
Absolutely. Yes, you can.
This is foreshadowing probably to later in the conversation, but my understanding is that you're using the pre-printed custom plates from Materialize. DuPuy Synthes.
DuPuy Synthes, and the bioengineering company is Materialize. But I don't. I use them in different ways than other surgeons use them, and my whole process is completely different. It's very different from other people.
Okay, and just
we'll go to that back later.
To lead into that question.
Yes.
To lead into what you were just about to explain.
Yeah.
So Dr. David Alfie, who was the last jaw surgeon I interviewed, uses the same plates from the same maker.
Yes.
And has explained to me that the use of those plates has allowed him to do a higher volume with the same quality. So it's interesting that you de-emphasize the role that those plates play in allowing you to do a higher volume. To you, there's still a need to really hunker down and dive into a case and give it time. And are your surgical times shorter than what they used to be prior to those plates, or am I just completely misunderstanding your use of those plates?
No, you are really, Ron, hitting the nail on the head. And it's interesting because when I asked my patients, what do people really want to hear about? They said, you have completely different processes than other people. I had a patient from UCI, University of California, Irvine. My office is in Newport Beach. I'm right near the airport. Most of my patients, like 80% of my patients, are not local. Anyways, her parents flew in from New Jersey. My practice manager or my surgical coordinator is from New Jersey. That's another unique thing about it. Anyways, so she wanted to know I said, we have a limited amount of time. I've got about 2 hours I can give you. First of all, most surgeons only give me half an hour for a consultation. We had a lot of stuff to cover. What do you really what's most important to you to accomplish during this conversation? It's like that's kind of was the first question I asked you. What do you want to cover? Or what I was hoping to ask. Your question to me is how are my processes different, right? So I told her there's initial process of getting a good history, going through, finding out, assessing what her knowledge basis is, if she's a good candidate for surgery. There's certain people that are just not good candidates, like people that are in high conflict relationships, have a lot of conflicting needs, like taking care of aging parents, children, legal conflicts, partnership context, or unstable personality states like borderline personality disorder, because they're just not going to be available. So there's certain exclusions, but there's initial data collection. So that initial data collection requires good quality records from an orthodontist. Okay.
I'm sorry, doctor. Were you saying that those types that you just mentioned are not good candidates for jaw surgery, especially people with certain life situations and certain psychiatric disorders? Don't make good patients candidates for the procedure? Now, I'd be very interested to hear more about that, but I also don't want to be interrupting you.
Like, let's just say you were going through a divorce right now. You couldn't show up for appointments. You couldn't follow post-operative instructions. You couldn't physically take care of yourself. You didn't have you're involved in a lot of conflicts where conflicting needs for yourself or conflicts with others. It would be so challenging. I would recommend that you wait until you're in a more stable place in your life before you want to have surgery, right?
So you acknowledge that this surgery requires a person to carve out a little safe space for it to occur in. There needs to be a certain amount of peace in their life, a certain amount of contentedness, perhaps, and relational stability, and also just time to heal.
Certainly relational stability, but my job is to guide them through a journey, which can be slow or fast, depending on what their needs are. But I had to optimize their journey, and it is a journey. And actually, most people's journey starts decades before they even get to me in childhood.
For sure.
I recently had a conversation with a woman. There's a pretty blonde hair woman on my website with these green eyes. I said, when did your journey start? She said, age 8. And that happened with extractions and retractions, which is another thing we'll talk about.
That's where my journey started too.
Yeah. Many people. It's my responsibility to guide them through this journey, and far beyond the surgery, if they need physical therapy, if they need speech therapy, if they need trauma therapy, if they need, I don't want to I did your surgery, got your money, sayonara, have a nice time in India when you go back there. It's like, that's not, I want to be able to sleep at night. Right?
Yeah. That's bad karma.
It's bad karma. Yeah. So she wants to know what the process is. I said, well, the first thing is data collection. We need minimal good quality orthodontic records, right? A cone beam CT scan, a good photographs, and either physical plaster models or digital models as represented in what's called an STL file from an orthodontist. That's the bare minimum, right? And a good physical examination and a good history taking and a good understanding of the patient, what their needs are, what their sources of support are, and so on and so forth. There's an old expression, seek first to understand before being understood. Okay. If I want people to understand what I'm saying, I need to understand them, right?
Yeah.
So I need good data. So that's the first thing. But when it comes to the final stages of surgery planning, I don't use cone beam CAT scans because the difference in quality between a 320 slice medical grade spiral CT and a CAT scan is like night and day. I can show you, I don't know if we can screen share here, but there is a staggering difference. For one thing, in a cone beam, a person's upright, right? There's no gravitational effect on the tongue. And we get all kinds of scatter artifact from braces. In a medical grade CT scan, especially with in light, which is Mimics. Mimics is the platform on which ProPlan is the software from Materialize. That software, now they're coming out with a second generation called Enlight, Mimics Enlight, and I was a beta tester for that. It's been FDA released in Europe, but not in the US yet. But that software can literally segment out any soft tissue. If I want to take a look at your lingual nerve or take a look at the lining of your sinus, I can get rid of everything else and I can just visualize that structure.
Wow.
Yeah. If you want to see a great video, look on YouTube. They're using Mimics and Light, Mimics. And I love the name Mimics, right? To look at coronary arteries based on a CT scan. And so the better the data collection, the more you can see. I can't treat what I don't see. So, for example, all my patients go to University of Southern California Arcadia Hospital. Their imaging center, they have a Canon Aquilion 1 scanner that scans at 300. It's a 320 slice spiral scanner. And by the way, I trained the lead technician who used to be the radiology technician for the one of the big Angels baseball team here. So because you can have the greatest machine in the world, but if you don't know how to use it, you're going to distort the airway. You're going to not get good images.
Right.
So it's the data collection. It's the quality control right from answering the phone, right from say, hi, thank you for joining me today, and just respecting the person. You can't parse out any part of the healing journey without we're also related. Everything either builds trust or builds uncertainty, ambiguity, fear. So it's the data, it's the technical aspect of that, the type of CT scan. And, and I've negotiated like really good prices. They give cash prices to all my patients. Literally, I send off an email to Summer Cerna and Ken Trolin, who are their technician and their scheduler, with an order for a CT scan, and I give the patient's name, and I said, Summer, would you please call so-and-so and scan? I've got a patient coming in on tomorrow from Mexico City, right? And he, Summer's going to get an email from him, and he's going to contact the patient and schedule him for a CT scan. He's also going to go to one of the orthodontists that I work with to get what's called a centric relation record. And that's a big area of misinformation in the community and even among surgeons for what is a centric relation record and could the condyles be in the wrong space. So have you heard that, or do you know what I'm talking about?
Well, it sounds like what you're talking about is trying to determine the correct place for the condyle, which is a major question.
Yes.
That's one of the things I was going to ask you is how do you plan around the temporomandibular joints in a surgery?
Yeah, great question. So centric relation is the optimum biomechanical position for the condyle in the fossa. The condyle is oval shaped. The head, it looks like looks like this, right?
Yep. Bring that into the frame. Yep.
By the way, this is another part of what I want to talk about, like my use of these models, right? So we'll talk about that in a second. Yeah. So that the optimal position for the condyle may or may not be coincident with the optimal fit of the teeth together. That's known as maximum intercuspation, or centric occlusion. Centric relation is the condyle. Centric occlusion is synonymous with the maximum intercuspation for the teeth.
And sometimes they're at odds.
Yes.
Yes.
Frequently at odds. As a matter of fact, people will posture their jaw forward, or if they have an asymmetry, they will be constantly moving and like searching for the optimal biomechanical stability, which is why they have sore jaws and they have in constant pain, because like, is it here? Is it here? So that's easy to capture and has been captured for years by people that do reconstructive dentistry, right? It's called a centric relation record. So you put a radiolucent material in the person's mouth. Either, usually we use a stuff that you squirt in through a little gun, polyvinyl siloxane or polyether. It hardens within about 30 seconds. And when the patient goes in for their scan, they have that in their mouth. So we know we're capturing just the correct centric relation. You follow what I'm saying?
Yeah, the centric relation of the joint or of the teeth.
Centric relation refers to the joint. Centric occlusion is the
Understood.
centric occlusion. So you can have a centric relation, centric occlusion discrepancy. That's where they're non-coincident, right?
So, for example, if your centric occlusion is in a recessed position and your joint is pinched because your jaw is too far back, although your bite is perfect, that would be a common example of a discrepancy that you would see in someone that had small jaws.
Yes. Just a little bit more graphic example. Usually I see this quite common when there's, it seems to be more common when there's probably in the neighborhood of about 3 to 5 millimeters of overjet. So people will posture their jaws forward and they will get into centric occlusion, but their joints are not in the right position, right?
Yes.
So, and that's why people are afraid of using this technology, because they don't know. As a matter of fact, even the document from Materialize said, they call it a bite wafer. If you are uncertain about the position, have the patient have a bite wafer in their mouth. So, but just because there's instructions doesn't mean people read the instructions. Just because you got a Canon Aquilion 320 slice scanner doesn't mean the person positioning the table, if the neck is kinked, that you can only assess the airway because there's a constriction which doesn't really show.
Yeah, speaking of that, there's been a lot of questions that I've been receiving recently about the importance of posture control when trying to determine airway size on a scan. Is that something that you account for too?
Yes.
Do you strap a person in to make sure that they're in a certain kind of head posture?
No. The scans that I take have their entire head all the way down to the clavicles, without distortion, without the ear straps, without straps or anything like that.
Okay.
And I want that patient to be in the position for the airway, which is where they naturally go into, because that is that's the position where the airway will be most open. Usually.
Yeah.
So and that's determined by the principles of mobility and stability, which I spoke about before, muscular tension, right? So as much as possible, I want the airway to be neutral. I want to be able to visualize the entire airway down to the vocal cords, right? Which very rare. You might see it on a cone beam CT scan, but you certainly won't understand the position of the tongue, right? Also, the patient should not be swallowing. On that, someone asked me a great question on that. Those GIFs on Reddit. The patient was swallowing at the exact moment the scan was taken, so you could see his palate flipped up. Shui kind of noticed it, and someone else asked me the same question. But in any case, it showed his airway went from, I don't know, I think about 130 to 400, square millimeters across. And both the pre-op and post-op were medical grade CT scans. So it's the data acquisition and the skill of the person that is using that technology is the first part. So that is the first step in the quality control process.
Right.
Do you want me to go on?
Yeah, sure. Yeah. You could continue telling us about, your onboarding process and what that looks like.
Sure. So the next step is to plan it out.
We talked about data, the importance of data collection
and getting a good history and examining the patient, understanding the history. If they're condyles, if there's a difference between arthritis and arthrosis of the jaw joints, right? People don't understand the difference, right? And
what is the difference?
Right. So
I've never heard of that distinction.
Yeah, there's different ways to define them, but the most common one that's useful is arthritis. Anything with itis means inflammation, right? So things that have inflammation are inherently unstable and they have the potential for degenerative changes, right? So, which means a change in the shape of the bone or the biomechanical structures that make up the temporomandibular joint, which is a complex joint. It's what's called as a diarthrodial joint. It slides and also hinges, right? So you have to understand the nature, how the joint works to begin with. You have to have a deep understanding of biomechanics, right? And bioengineering, by the way. So if there are certain features of arthritis, there's arthrosis, which just means changes in the shape, people will not have pain in their joint. If we take serial x-rays of the joint, they will not change over time. And if we use a radionuclide in the blood, which will collect and show increased activity in the joint, it will not light up. So it's pretty easy to understand whether a joint is stable versus unstable. And that's what allows people to do surgeries like I do, or do inverted L's when there's basically no condyle. It's like a little stump, right?
Right.
Yeah. I have a model here from a man that was punched when he was about 20 years old. His huge facial history, I put it on Reddit, by the way. And he's got a very abnormal condyle, but I put that condyle in the right position where there's the highest probability that will hold up. He probably has a 1 in 10 chance of having a problem in his joint and needing a total joint. That's my boundary, my personal boundary for not participating in something. And I always set my own boundaries, even no matter how much someone wants me to do something. Yeah. So there's the data collection. The next step is to plan it out in 2D. So for that, I use dolphin imaging software. And so I'm creating what's called a 2D visual treatment objective. Usually at that case, I'm superimposing, if I have a good quality 2D photograph, I'm superimposing it on top of what's called the cephalometric tracing, so the patient understands what their face will look like. And it's not a monologue from David Bell, it's a dialogue. What do you want, Ron? How do you want to look? Okay, if you want this, can you accept that your airway will be such and such? Another part of the process is for patients to have a sense of clarity about what they want. That requires introspection.
Right.
Most people vastly underestimate what's possible. They need a lot of education. So someone asked me on Reddit the other day, they want a free consultation. And I said, well, I don't even have a diagnosis. I can't even tell you what your options are. I don't know what your long-term needs are, your short-term needs. I want to come up with a solution that will work for you.
And are you talking about now the tension between aesthetic and airway when it comes to jaw surgery?
No, it's not a tension. If it looks good, it works good. If it works good, it looks good. Form follows function.
Do you think that you get to a point where if the expansion is so much, maybe that's great for the airway, but it can start to look a little bit unnatural at that point because of the way the soft tissue reacts?
It will if the surgeon is not skilled at designing.
What do you mean by that? I'd love for you to say more.
Yeah. The best way to illustrate that is I had a man come to me recently who had a previous ease procedure. I have a lot of, well, I don't want to say ease. Let me just say a maxillary expansion. People come to me having previous distraction procedures on the maxilla. I don't do those because I don't find them to be necessary. But we can talk about that later. That's a frequent question I get asked.
That's a major question in the space.
That's
for
a
sure.
huge question. And also condyles. These probably are the biggest questions I get asked, which I answer over and over again. I'm starting to get some different questions finally.
In fact, the talk that I'm giving at MewCon next weekend in New York is jaw surgery, MARPE, or both. That's the talk. So it's the most common question that I get.
Yes. It's the most common question or concern, and it's a source of frequent misinformation, by the way. So undoubtedly, you'll know a lot more after speaking with me today. Your question to me, remind me what your question was.
Yes, we were talking about the tension between aesthetics and airway, the patient's sort of discernment when it comes to choosing that. Right. And you said there is no tension. It's different. You would frame it differently than as a tension.
It's the job of the surgeon to come up with solutions. Okay, so I showed recently a 4-piece maxillary osteotomy and 6-piece mandibular osteotomy on Reddit. I showed that about 2 weeks ago or something. This man had a previous distraction procedure for the maxilla, and he went to another well-known surgeon that has a high-volume practice, and I know because I see patients come to me with their treatment plans, right? And the only thing they offered him was a advancement of the mandible of 6 millimeters. This man is in his early 40s. He has a fatigue severity scale of 63, which is the highest possible score. He has a very demanding career. He's at the prime of his life. And unless he does something, he will soon be disabled. So he came to me for a solution to his problem. It's my job, Ron, I'm not a magician, but I have been designing and building things since I've been a young child. And so I designed a 6-piece mandibular osteotomy with a sub-apical osteotomy.
What's that? What's a sub-apical osteotomy?
Yeah, so a sub-apical osteotomy is I took out the two first bicuspids. The mandibular first bicuspids will be extracted either in the operating room or a few days before, right? And that segment of bone containing from canine to canine will be moved backwards, right? Well, I showed a picture, so it's hard to. Can I screen share?
You can screen share. Yeah, that would be great, especially as we start to get into some of the more technical stuff.
Yeah, it's really hard to talk about stuff.
I know surgeons have their own language for describing what's what in the face and where it is and the plane that you're talking about. And
I never do that when I'm communicating with patients because it's too fuzzy. There's too much ambiguity. There's too much uncertainty.
Yeah.
And so
you should have the ability to press a button at the bottom of your screen that says present.
Present, yes. Okay.
And hopefully your browser has permissions to allow that.
Share screen. Okay. So here's a post. It's the name of this post is what is a 3D surgical pre-plan. Okay. Mm-hmm. And I'm going to make this big. And here is a 1, 2, 3, 4, 5, 6-piece mandibular osteotomy.
Wow.
4-piece mandibular osteotomy. I described what a pre-plan is. That's a side view there. That is the other side. That's 3/4 view. That's the bottom up. And that are the movements. The incisors came forward 5 millimeters. POG, which is a Pagonian almost 23 millimeters.
And can you tell us what the Pagonian is?
Pagonian is the chin.
Okay.
I'm going to move back. This is the Pagonian right there. Right. Pagonian. And so these came forward 6 millimeters. I could literally not even do 6 millimeters, not bring it forward 6 millimeters, and still we'd be going from 6 millimeters in the airway to what's 23 minus 5, 18. I would still triple it, right? So what is a sub-apical osteotomy? I did, in this case, 2 mandibular bicuspids were extracted. You notice that is the canine there. That's a bicuspid. That's the molar. So he's missing a first bicuspid. This piece of bone over here, the gold-colored one, was moved backward, right? The chin was moved forward. The whole facial structure was rotated counterclockwise. The arches are coordinated by doing the maxilla in 4 pieces because the shape of the arch changes slightly over here between the canine and second bicuspid, and that canine, I want that canine to be in the ideal position, so I have a little bit more control of coordination of the arches by doing the 6 piece. This was actually a pre-plan. We'll talk about what a pre-plan is later, but I actually described it. What is a surgical pre-plan? So that's a sub-apical osteotomy.
So the sub-apical osteotomy specifically refers to the mandibular osteotomy with the bicuspid removal and the cutting of that front part of the mandible and moving it back. Is that right?
It's a general term. I've showed other examples of sub-apical osteotomies with distraction on this website. But it refers to a procedure where I'm cutting below the apices being the roots of the teeth. I'm cutting below the apices of these teeth.
Right.
And moving the bone forward, tilting it forward, tilting it backwards, moving it forward or moving it backwards, or moving it up, moving it down. Any one of the 6 geometric movements, which is forward and back, up and down, side to side, pitch, roll, and yaw. I can move that piece of bone wherever I want, right?
And as you would explain it to a fourth grader, why was the bicuspid removal necessary in this case? What did it allow you to do? If you could just kind of explain that geometrically for us. Right.
So if I want to open up the airway, I have to bring the hyoid bone and the tongue forward, right? So, which means I have to bring the chin forward because the muscles attach behind this piece of bone, right?
Mm-hmm. Mm-hmm.
So, if I wanted to move this far forward without moving the upper jaw forward so much that it would look unnatural, I had to come up with a solution and to move this very far forward, right?
Mm-hmm.
Without making this look unnatural. All I've done is move this 5 millimeters forward. And that's under discussion. Nothing gets manufactured until the patient approves of it, right?
Right.
The patient see every part of the quality control process. I have a feeling he'll probably ask me to bring it forward 2 millimeters. I don't know. We'll see. He's having his surgery in 6 weeks.
Mm-hmm.
So this is the goal, is to protect his brain, his brain health, and get this forward without making him look...
The chimp lip?
I don't like using that term, but it's without it looking cosmetically unbalanced.
And what is the specific cosmetic unbalance? That the upper lip area comes too far forward with respect to the midface?
I think he'll be just fine with this movement.
Yes.
But he does have a very small nasal bone. You can see his nasal bone.
Mm-hmm.
There's his nasal tip. there's different standards. If I was, say, Ben Walleen, I would put the teeth near the soft tissue glabella, which is over here. If I was Alfaro, I would put the teeth near what he calls the Barcelona line, which is the soft tissue nasion. So everyone has different standards, and it's highly dependent actually on the height of the osteotomy. So I don't make the osteotomies down here at this level, because if I make them down there, I'm moving the teeth way forward and leaving all this paranasal area behind, right?
Right.
I want to bring this far forward. I'm cutting, and I could have even cut much higher than this. I could have cut out there, right? And brought the whole submalar area forward.
So you can cut above the zygomatic root? Or am I misunderstanding? Would that still not be above the zygomatic root if you were to cut that high?
Let me make sure that our definitions are the same.
Yes.
I'm going to stop sharing a screen for a second, okay?
Okay.
I'm going to show
Actually,
you.
I can control that. So,
Yeah. I don't know if I'm showing. Do you see this model here?
Yes.
Okay.
I'm going to put you in solo layout just so that we can get a better view. But yes, you're there.
Okay. Do you see how high I've cut it?
Keep rotating it. Okay. Yes, it looks like you. Interesting. That's that's kind of an odd shaped Lafort cut, isn't it? Where you kind of cut down around the zygoma, but above it on the inside.
Ron, I can design an osteotomy any way I want.
Right.
As long as it biologically makes sense. And I can stop sharing the screen for a second.
Okay.
Because to make sure that I am holding it in front of the camera properly. Yeah. So I'm cutting it way, way up high, right? In the middle of the cheekbone, right?
Right.
Right?
Yes.
So
that cut is occurring, I mean, roughly here.
Let me show you other examples. Other examples. So this is another thing. Like, I always have models made. So I always have before and after models. I don't know if you can see here. It's actually, a lot of times it's easier to see the plans. I'm cutting it high so that what's called the paranasal areas comes forward. Because if you cut it just at the base of the nose, then this is going to look very deficient.
Correct. Which is a major aesthetic concern that people have with doing this procedure. Of course.
Right. And people ask me that question all the time. Like, are you going to preserve the concavity of the lip? Of course I am.
What does that mean?
What does that mean? Well, the lip is, if you look at the face from the side, the lip is concave, right? Mm-hmm. From the side. So it would look unnatural if it was convex.
Try to explain the geometry of what you're describing a little better. So this is for a profile view, is that right?
Yes.
Okay, so preserving the concavity of the lip, does that mean? Yeah. Does that mean this curve here, like this?
I'll show you in a second.
Okay.
So this is a patient who had 4 bicuspid extraction, retraction. She's the person who told me her case went back to age 8. So, by the way, if you go to my website, you can see the treatment plan for anybody here. And we can load down the treatment plan. And you can see what I did.
If that's loading up into a different tab, you have to make sure that you share the other tab.
Okay. So, concavity. So here is the upper lip. It's concave. I don't have a straight profile on her, so this is not a great example. But
it's probably a good enough example. Okay, sure. Okay.
So this patient is actually very early out of surgery. She was kind enough to allow me to put her patients on. But the lip is still a little bit swollen, and some of the concavity has been lost at. This swelling takes about a year to go away, okay? This maxilla was expanded by about 5 millimeters in transverse dimension. Her chin came forward 18, I believe.
Wow.
See this nice concavity at the philtrum? There, you still see, that's a concavity, as opposed to this is more convex, but as I say, she's still early out of surgery. And by the way, the nose looks half the size. And that's not a nose job. That's just because of a little bit of work that I did on the nose. And the fact that the nose looks a lot more proportionate to the rest of the face. Her maxilla came forward 8 millimeters, I believe. Her chin forward 18.
Wow.
Right?
Wow.
So this is the most common operation I do, and 3-piece maxilla, 5-piece mandible. So let's stop sharing the screen, and you can go on to the next question.
Yes. So in a nutshell, and I don't want to keep beating a dead horse, but in a nutshell, we're talking about concavity at the philtrum, which is the nice aesthetic result for the upper lip.
Yes.
And as opposed to what you don't like to call chimp lip, which is a kind of convexity at the upper lip, where the upper lip starts to look, like.
Yes.
Like
and by the way, a lot of that stuff has to do with the height of the cut. So, as I said, if I make the cut down there, right, I'm leaving all this paranasal area behind. Right?
Yeah, are you showing on the image what you're talking about? Because we're just sharing a cut-off piece of that tab with the woman who had the fine result there.
Okay. I'm trying to share my screen again. All right, so we're back to here. If I make the cut too low down here, right, then I'm leaving all this behind. The other thing that has to do with concavity is the angulation of these teeth, okay? If this is tipped too far forward, then I'm going to lose that concavity. If it's tipped too far back, it'll look too protrusive at the level of the teeth, and the angle will change. So the angle of these teeth with respect to the horizontal should be around 115 degrees. And that's where I place my patients typically.
Now, this whole manner of discussing things in terms of, millimeters with respect to this other point in the face or on the skull, and or degree of rotation with respect to this other place, is this what we call cephalometrics? What do you call that science of facial analysis?
Cephalometric analysis. So there's many, many different types of cephalometric analyses. Those cephalometric analyses were primarily developed by Caucasian orthodontists living in the Midwest, and in those type of people. So they're based on certain norms, and the programs, the planning programs, actually have those norms built into the algorithms that show the soft to hard tissue changes. So there's calculated values that show how much the soft tissue will change in response to a hard tissue change.
Right.
And so that whole science where we define a landmark, whether a dental landmark or a bone landmark, is called a cephalometric landmark. And each landmark can be moved in 3 linear ways: forward and back, up and down, or side to side. And any 2 points can be removed in any rotational ways. We can move them clockwise and counterclockwise, called pitch, right? I remember that because I'm pitching, right? Okay. Yaw, which is from side to side, that's a Y. That's why I remember that one, right? Yeah. Pitch, yaw, and cant or roll. Pitch, roll, and yaw. Those are aviation terms. I think I've showed a picture of that on Reddit too. I think it's a picture of the space shuttle in pitch, roll, and yaw. So that's how we can move things in space. When you're designing a face, solving problems, aesthetic problems, airway problems, asymmetry problems, we always want to think of balance. If you try and make any one thing perfect, you may make something else less perfect. So it's always the balance, but I never really want things to be off more than like by a millimeter or two when I'm balancing things out.
And
And that creates a harmonious, like there's no ideal face. It's just what's ideal for you.
Right. And so when you learn to do these surgeries and when you go through schooling, for example, do they teach you a certain definition of beauty?
So, yeah. So I had a very kind of stellar, storied journey. I I had a fine arts degree, then I got a science degree, then I went to an Ivy League school. I went to Columbia University in New York City, and then I went to the top training program in the country at that time, which is LSU. I started medical school. I took a leave of absence to practice dentistry, went back to medical school at LSU, did my general surgery training at the UCSF site in Fresno, California, and did my surgery. So I did a lot of orthognathic surgery during residency, and I loved it. I just thought it was the coolest thing in the world. But I didn't know jack about treatment planning because I was just the resident. I would show up for the surgery and I would do it, right?
The plan would already be there waiting for you and you would execute on it.
Yes. When I got my first job out of residency, which was at the epicenter for training for orthognathic surgery, which was University of Texas Southwestern Medical Center, I was on staff at one of the training centers, which is John Peter Smith Hospital in Fort Worth, Texas. And the people that wrote the textbooks were like basically my partners. So one of them was by the name of John Stella, okay? There's a famous 4-volume set, which I have sitting on my table here. You can't get stuff like this. Dental facial deformities, surgical orthodontic credit. This is an extraordinary book, okay? Because it's very granular. There's very old techniques, but every week we had conferences with the residents where Dr. Stella would have the residents literally take the models and cut up the teeth. It's called model surgery, reset the teeth, do old school treatment. That's when I truly learned how to treatment plan. And that skill from doing hundreds and hundreds and hundreds of cases in a very short amount of time, plus having a huge volume of operating experience and embodied skills back to age 5, really, I could really rapidly learn how to plan things.
Right.
In a cosmetically pleasing way, things that were biomechanically stable to optimize the technology. But
you understood TMJ back then too?
Yes. Also spend a lot of time with Larry Wolford. I used to do joint surgery, but I don't do it anymore. Larry's the guy to go to if you want joint surgery. He doesn't use custom hardware though, Right. So everyone has different wisdoms and different skills. Okay.
Totally.
So if people ask me, do you do joints? I say no.
Do you think joints are overdone sometimes? Do you think the joints are more resilient than we give them credit for?
I think to a certain extent, there's an argument that says, when you hammer, everything looks like a nail. Okay. Yeah. So that's what I'll say about that one. People could say that about David Bell. They could say, well, you just think that everyone should have orthognathic surgery.
Yeah. And
so, we all have our perspective and our beliefs based on our own experiences.
Well, Dr. Alfie shared with me a view that sounds similar to yours, where he said, basically, he thinks that sometimes joint replacement is overdone, and that if you just give the joint, if you just put things in a healthier position, that the joint can function better than you might expect, and that the person will stabilize and heal, and that there's precedence for that in other types of surgeries where the joint is kind of given more credit than people who do a joint replacement give it. So like he tends not to recommend joint replacement very often at all.
There's things can be partly true, mostly true, not true, whatever. So there's a lot of truth to that. But remember, I distinguished between arthritis and arthrosis before. Yeah. That's an important distinguish. And also it depends on the design we used to think that if we used flexible plates, it would be harder on the joints, but that would just cause this. I don't see that. As someone asked me my record for bringing a jaw forward, I showed a case on Reddit where I brought the jaw forward 30 millimeters. She had hardly any joints. The micro trauma from movements for flexible hardware, I believe, is a very big cause. If people relapse, it's usually around 6 months. This patient, I did her with custom hardware. She is dead stable. Also depends on whether the skill of the orthodontist and whether patients have been properly decompensated. That's another issue. So
we're talking stability now of jaw surgery.
Long-term stability. Yeah. And by the way, I want to digress because people ask me, what are the long-term studies on 5-piece or 6-piece mandibular osteotomies? There aren't one. They aren't. Okay. There's some limited studies, but the nature of evolution of surgical science is that we incrementally build on what's been done before. By the way, that 6-piece mandibular osteotomy is described in this book that's got drawings. And I show the example of that on Reddit because people are asking me about osteotomy designs in general. Mm-hmm. Mm-hmm. So I want to, in the time we have remaining, there's a couple of things I want to point out because you were kind of asking me about my quality control process. So the other part of that is the engagement of patients during not only the 2D plan, but their 3D plan. Once they have decided they want to have surgery with me, they are required to be on my planning sessions with the biomedical engineers from Materialize.
Wow, the patient is in on that? I've seen that process happen.
Absolutely, absolutely. So the other thing is what is the other quality control thing? So I learned very quickly that patients don't always have an ability to see their face in a 2D opaque mask or translucent mask. So I use a technology called 3D MD, which is a system only used by 2 or 3 other surgeons in the world, which allows 3-dimensional images, photographic quality with motion capture up to 60 frames per second of a patient's face, which then gets superimposed on the 3D scan. I can show you examples of that. I'm kind of hitting the high points. But if we can go to Reddit here for a second, I can show you. So I'm going to, people asked me this question too before. I'm trying to give references so if people don't remember everything or they want further detail, they can see it on Reddit, by the way.
Sure.
So here's presenter mode and screen share. And here is Reddit. Okay. I think there's a lot of good questions. It's amazing how many views this one, just 16,000, like in 3 days. Extraordinary. Mm-hmm. The interest. So someone asked me here, these were done by Shui Kai, something about, we're talking about quality control right now. Mm-hmm. And what constitutes, this is the picture from that book from Stella, right?
Can you click through that or zoom in on it? Maybe pinch to zoom on it? Yeah, it must have opened up in a different window.
Yeah, so I can go back to here. Okay, sub-apical osteotomy. Mm-hmm. Right? Mm-hmm. So it's, some people could say I stole this. People say a lot of things. Whatever.
Yeah. Well, good artists copy, great artists steal, right?
That
was Banksy.
Yeah, and guess what?
I'm sorry, that was Picasso, not Banksy.
Yeah, so the inventor of calculus said, if I'd seen farther than other men, it's only because I stood on the shoulders of giants.
Indeed.
Yeah, so where am I looking at? I'm going to show you what a 3D MD scanner looks like. Actually, I'm going to show you what the image looks like. So I'm going to stop sharing here for a second. This is 3D MD, right?
Mm-hmm.
This is superimposed over the surface topography of this, as represented in an OBJ file, is superimposed over the surface topography of the soft tissue of the skin. And as the bones move, the surface topography changes, as represented in this file. So patients see this in real time, can make changes to their surgical preferences according to looking at their own face. And so this is technology that's only used by 2 or 3 other surgeons. It's used for designing, like.
Can you show us an example of how adding an extra 4 millimeters or something to the mandible would affect this image?
I can do that. I'll show you his.
Do you find that software is pretty accurate?
ProPlan is very, it is. These algorithms, I find ProPlan is probably the most accurate. And this was a conservative advancement of the maxilla. This was 8 millimeter. The patient didn't want to go above 8, but that's also the guy that had that massive expansion in his airway. Those gifts were taken 3 weeks after surgery, by the way, the post-operative CT. But I'll show you what it looked like with 3D MD superimposed. So here is this patient had a previous maxillary distraction procedure, couldn't breathe through his nose, went to another well-known surgeon who was going to do a one-piece maxilla on him. I said, well, how's that going to work? Because you still won't be able to breathe through your nose. So we decided to expand the maxilla. If we expand the maxilla, then we got to expand the mandible, right? So that's the mandible expanded. And here is the plan, going through it over here. There is the pre-op and post-op images, which basically look the same. You see the concavity in the lip there, by the way, as after what you saw on the 3 weeks. He didn't have that much swelling, but he still had swelling. So those GIFs on Reddit are 3 weeks after surgery, but here is 3D MD superimposed, right? So you see a very accurate representation of his face.
Wow.
We could look at that in 3D, by the way. I could actually have him talking and spin around the picture of him talking, because it's up to 60 frames per second motion capture.
Wow.
Using this kind of technology is what really, so what is quality control? Quality control is predictability, safety, communication. They're all parts of what constitutes quality, in my view.
So as part of the planning process, you bring the patient in?
The patient's in. We have the engineers that I work with. I work with the best engineers, and I ask them to send me screenshots, or I use Otter AI to take screenshots of the meeting. I send them to the patient, and they think about it. And we can go back, we make further changes, but nothing gets manufactured until they don't even go to the design process until the patient is happy with the cosmetic outcome. Then, once the patient has said, I like this cosmetic outcome, then we're into the design process for the hardware and the cutting guides, which I'll show you in a second. And there is a big difference between Dr. Alfie and myself, with all respect, in that regard. And then nothing gets manufactured until I approve of the designs. So they send me the initial designs, which generate. So I have before and after models of everything made. This is a 3D model. I can see all the teeth.
Bring it into the frame, doctor, please. Sure. Yep.
So I can see all the roots of the teeth, where the nerves are, and so on and so forth, right? So these are the cutting guides. And you notice how many screws are. There's between 16 and 18 screws, okay? This is what you need in order to create long-term stability. These are made of titanium based on a CT scan.
So these are the guides, right?
These are the guides. You're looking at the guides, right?
So those get bolted in those get screwed in first, and then those are not the plates that stay in permanently.
No, you see the tunnels?
Yes.
These little tubes, that allows me to angle the drill and the screws to not injure nerves or teeth, right?
Mm-hmm.
Right. Then
the guides are anchored onto the teeth as well to ensure that they're in the perfect position.
Right now, the FDA has approved for titanium guides on the mandible, but not the maxilla. And those just got approved about 3 months ago. Yeah. So where they really come in handy, what I find is the back of the mandible, not so much in the chin or in the maxilla, right? So, but I also have the maxillary guides in two pieces because it's a lot easier to get them in and out. And I designed them so they are locking anteriorly, right there. And again, everything's angled correctly.
But I thought you just said that the maxillary guides were not FDA approved. What am I missing?
For being supported on the teeth.
Oh, for being supported on the teeth. Okay.
Yes. In the mandible, they are supported on the teeth. This one at the front doesn't make much of a difference. It's pretty easy to get this. On the back, it can slip. So this is actually kind of idiot-proof. Yeah.
There's a lot more tension at the back, and it's a lot harder access.
Yes. And then the plates are manufactured. You see the amount of screws. Other surgeons will typically use 3 screws per side. I'm using like 16. And they're long screws. They're bicortical screws. They're up to 14, 16 millimeters long. And each screw on the report tells me how long this screw is. Right? So it's
could you put that back? Could you put those plates back up? I just want to compare them to what I saw with. Yeah, those are huge. Those are even bigger than the plates that Dr. Alfie uses.
Well, with all due respect, and you can use your discretion of whether to cut this out or not. But patients comes to me with his designs, like he's using 6 screws per side, right? Mm-hmm. So this is like a lot more, and they're a lot bigger screws.
But he's still using a lot more than someone who's doing more traditional approaches of bending plates on site, or
typically people use. The common thing is to use 3 screws at every side of the osteotomy, and the basis for that. And if you noticed from my maxillary plate, I'll show you the maxillary plate. I'm trying to get through. I want to be respectful of your time. Each location's got at least 3 screws. Why is there 3 screws? Because you need 2 screws to prevent rotational instability. But if 1 screw doesn't hold, you need a 3rd screw. Mm-hmm. Does that make sense? Mm-hmm. By the way, also these mandible plates here, they go all the way back there. Do you know why they go back there? Because an uncommon complication, I've had probably 5 in my life, is what's called a bad split. Okay. Mm-hmm. And so if you have a bad split, if you want to prevent harm to the patient, you have to terminate the operation to prevent an untoward occlusion or nerve injury. But under some circumstances, you can have these screws back here, which will allow you to put the pieces together under some circumstances.
Right.
So it's all in the design. So quality control. So it's the design of the hardware, the fact that I have before and after models, which allow me to have X-ray vision. If there's any question how a plate fits, how a cutting guides, I tried on the model. Also allows me to educate my team in the operating room. Right, a lot of what makes a surgery go quickly is having a well-defined team. There's so many things, Ron. Just off the top of my head, most American surgeons use American-made loops by Design Survision, Surgitel, Orthoscoptic. I don't use that. I use Zeiss. Okay, Zeiss.
Like my Sony camera.
Yeah, Zeiss is a 250-year-old glass-making company, and I use actually one up from Zeiss. I use a Zeiss head frame. I got all this stuff on my desk here, which is I do so many telemedicine things. These are, you see what that says?
Yes.
Swarovski, okay? Same people that make glass, right? These Zeiss would be considered the Porsche Turbo. These are the Rolls Royce.
Wow.
And there's a light that goes on here. Yeah, this is because why is this better? First of all, it's easier on my neck because on inflection, it's called the declination angle, allows me to be more relaxed during surgery. The size of the beam on here is perfectly matched to the size of the visual field. There's no chromatic aberration. There's no spherical aberration. It's just, even the instruments that I use, there's very few companies making good instruments. Walter Lorenz was a 250-year-old German company. They're out of business. I had to get most of my instruments on eBay, and I can find good quality instruments, or there's some new ones that no one ever used. They're still in the original packaging. But every little thing. The other thing, too, that I'm going to probably start instituting is I'm probably going to have an HD camera on my headlamp, because it's very hard for who's ever assisting me to really see. You're looking at a tunnel inside a tunnel. So when surgeons do laparoscopic surgery, they're looking in a camera inside the belly, and the assistants are looking on the screen. So I'm planning on having dual monitors. So if I'm operating on one side of the table, then the assistant can see exactly what I'm saying on the other side, and vice versa. So it's all these tiny little incremental things that add up to quality. Mm-hmm. The other things we were talking about was surgery first approach, right?
Yeah. People
don't want to go through a year and a half before they get to the operating room, right? So you understand that. So I've posted multiple posts on that on Reddit about surgery first approach. So the present way that it's done is people do maxillary distraction techniques, right? To expand the maxilla, to increase the size of the nasal vaults, to a certain extent the size of the nasal aperture, otherwise known as the the piriform rim. And but I see a lot of people that have gone through these procedures, and there's a growing trend. They're coming to me, they still can't breathe through their nose.
Are we talking about like an MSE, a maxillary skeletal expander, a naso-maxillary expander?
Yes, all of those things, right?
Yeah.
Right. And there's a lot of problems with them. Asymmetric expansion, as you know, a lot of things. So I used to do SARPs, a straight SARP. They worked 100% of the time. Why? Because I cut them straight across, right? If you cut them down like this, they're going to bow out like this. But if you cut it up here and you leave space, they expand perfectly straight. It's kind of just geometry.
Yeah.
I would open that thing up, test it, widen it up to 12 millimeters, bring it back down just to make sure it was moving without hindrance, okay? Mm-hmm. And maxilla is super loose. It's almost like falling off, okay? Mm-hmm. But I can tell you something. People go back to work the next week and expanding at 0.5 millimeter a day. I don't have to do that anymore. Why would I do that? I did that about a year ago on a man that was relocating his family to Japan because he was not in financial position or logistic position to have orthognathic surgery. So I did that, a dramatic change in a very short amount of time. But I can very safely and very effectively expand a maxilla up to 10 millimeters. I think my record is 15. I've showed multiple images of that on Reddit. And why does that work? Well, it has to do with the surgical technique. The specific surgical techniques allow me to do that. And then the oft asked question or opinion of non-surgeons is you can't expand the airway in the nose by doing a segmental maxillary osteotomy. That's completely false, okay? I cut it, the side walls of the nose are cut up really high. So just think of it, I'm taking this room here, I'm taking the bottom half of it, right? I'm cutting it in half, and I'm making a lot more space in the room because I've cut it. But if I only made the floor bigger, it wouldn't be a bigger room, right? Right. So there's a lot more room. I can also make the doorway bigger by removing part of the piriform rim. If I'm impacting the maxilla, I will lower the doorway by dropping the piriform rim. I will also lower the entire floor because the bone is usually very thick there. I can drop the whole floor. People don't want to go through these preliminary procedures, have them fail. There is one indication for distraction and or surgically SFOT, and that is for what's called the arch length deficiency. What is an arch length deficiency? If you add up the width of the teeth from front to back, or what we call mesial distal, add up those numbers and draw a line around the parabola of the arch. If it's a significantly greater, the teeth won't fit. You'll get crowding, right? So you can't fit the teeth around the arch. So when you distract it, you create space up front and you can redistribute the space, okay? That would be a valid indication, which the analogous of that situation is a mandibular midline distraction osteogenesis procedure where you make a cut and you widen the front of the mandible. In that case, you're primarily increasing the distance between the canines and or in front of the premolars. So if you have a congenitally missing incisor or a lot of crowding between the incisor, now you can unravel that. In certain cases, you could avoid extraction of the mandibular first bicuspids, right? It's a different procedure with different intentions. I want to quickly I'm covering a lot of ground really quickly. Am I losing you by any chance?
Nope.
No. So the other thing that people I was interested in, so we talked about a low volume, high quality practice, and I'm telling you all the things that go into that. So the other feature of my practice, remember, it's only a year old. I've been doing this for many, many years. It's all I've ever wanted to do. It's my hobby, my passion. I would do it for free. Is everyone that works with me has had surgery by me, will have surgery, or has had a loved one that have surgery. And I want to pay homage to my extraordinary practice manager, Kareem. He approached me after seeing another well-known surgeon, and he immediately recognized that he felt much more comfortable with me. And he had an intense interest in my practice. So Kareem is an interesting guy. He just turned 30. He joined a company that makes apparel. And he took that company from single digits to 8 digits, high 8 digits in dollar sales in 5 years. He has a gift for understanding business, connecting emotionally with people. But I didn't know him, and he was a patient, so there's a potential conflict of interest, right? So I said, "Oh, I'm honored that you have an interest in my business." So I met him last September. He had a missing mandibular canine, or missing mandibular incisors, so his intercanine distance were discrepant by about 8 millimeters, or 6 or 7 millimeters. Well, you can't, do that. And by the way, I'm disclosing very personal information. So it is a feature of my practice that I ask permission of all the people so that I can disclose this medically. Trust takes time to build. We've talked about that before. His parents picked him up after his surgery. And it was immediately apparent to me why, I remember saying this, it is so obvious to me why you have these personal qualities because of the way your parents are. And I gave him a small job to do at the beginning. And some patients were not getting approval through their insurance carriers for their insurance. So I said, why don't you, I would give them super bills and, file the paperwork, nothing would happen. I said, why don't you work with these patients, and if you can get them approval, you charge them a fee, 10%, And if you can't get them approval, they don't pay anything. There's only one company in the country that now does that. They're called
Paxos Appeals.
Paxos, and they got a waiting list, right? There's these 3 kids from Stanford. So I would say to patients, how's Kareem doing? Oh, Kareem's great. I got nothing but positive feedback from my patients because I needed to trust him that he would be really, truly advocate for my patients. And I really only brought him into the practice in February. The practice is 13 months old now. And we have consistently, in very short order, been able to get people reimbursed at, not always, but most of the time very quickly, they're getting reimbursed for my services as though I'm in network, which is extraordinary.
Wow.
And we will.
So you have your own in-house Paxos Appeals, basically.
Yeah, but we're very careful to not have any conflict of interest, because a patient could say, well, you didn't try very hard and now Kareem's just trying to cash in on this. Right. Well, that would derail the practice. It would destroy trust. It would destroy goodwill. We would never do that, but we are now, the other person that works with me is going to be doing the insurance just to maybe appease anyone's fear. But Kareem, who had an HMO, so we'll escalate it to the California Department of Managed Healthcare, and their legal department will take it up that high. He had an HMO with the worst company. He got every cent that he paid me back for his initial surgery. And I'm honored, actually, because I'm going to be either doing a 5-piece mandibular osteotomy, 3-piece maxillary osteotomy, or 6-piece mandibular osteotomy, and 4-piece mandibular osteotomy in about 6 or in mid-October, for my good friend, patient, and practice manager, Kareem. The other person that works with me is a woman by the name of Lauren Connerly. So how did I get to know Lauren? A patient from New Jersey contacted me, and I did his 3-piece maxillary osteotomy, 5-piece mastodomy. And I actually see patients in my home. I have malpractice. They literally are here. So
they go to your house?
Exactly. I have an office in Newport Beach, about 3 miles from John Wayne Airport. As I said, most people from out of town. So I used to operate exclusively at Quantum Surgery Center, which is at the south end of the airport, and the office is right above that. Now I operate at South Coast Surgery Center, which is across from South Coast Plaza, which is still 3 miles away from here in the other direction. So I got to know his girlfriend of 8 years, Lauren Connerly. I would see her every day. And one day I mentioned, I'm looking for a surgical coordinator. And I require patients to be here for 3 weeks after surgery, but I want to get them home sooner. As soon as all the incisions are closed, I can safely let them home. Unless they have some other kind of weird thing, but that the chance of that happening is not really. So I got to know Lauren very well. And the day before they left, she said, Dr. Bill, are you still looking for a surgical coordinator? I said, yeah. And her boyfriend, I will call him Joe, said, yeah, she's really good. She does scheduling for a physical therapy. So she works from home. She is kind. She's nice looking, which doesn't hurt. Most importantly, I trust her. I trust her to take care of my patients, to be sensitive to my patients, to do things efficiently, to not drop the ball. I trust the people that I work with, and they trust me with their own faces, with the welfare of their loved ones. And that is a very special thing that I'm extraordinarily proud of in my practice, as well as being part of this community. So that is what quality and trust and safety mean to David Bell.
Wow. Yeah. Thank you for sharing that about your team. They sound like a wonderful group. And
I'm really proud of them.
Yeah, that's...
I'm proud of you. I'm proud of this community for advocating for self-advocacy, for staying out of victimhood and getting into survivorhood.
Sure. Yeah, amen. Well said. I am too. And I'm grateful that people like you are out here to actually help us accomplish the vision that we have for breaking out of the prison of our own face.
That's very well said.
At the end of the day, talk is cheap, and you need someone to do the osteotomies.
Trying to think if there was any other. So we talked about surgery first. Just a few things about doing surgery first and orthodontic decompensation.
Yeah, who's a candidate for surgery first and who isn't?
Okay,
we could talk about that.
Yeah. So we are now working with a protocol. I have a gentleman, I see this all the time, that have gone through. I showed several cases on Reddit for surgery first approach. Okay. So how does one do that? So when you plan out osteotomies, the DICOM files, they're called DICOM files from the CT scan, are converted to STL files, which are the same type of file format that's used for digital scanning of the teeth with technology called iTero, which is the basis for Invisalign.
Correct. Yep.
You follow me so far?
Yes, absolutely.
Okay, so when you have an Invisalign plan, well, I'm giving away all my secrets now, but who cares?
Surgeons are so stubborn; they're not going to change even if they hear your plan, your methods.
Yeah, you can't look at a book and just say, "I'm going to do this."
No.
No, learning is experiential. You don't learn to sail a boat by reading a book on sailing.
No. Certainly not.
Yeah. So when you do the Invisalign plan, that's based off of two different approaches. One is just by taking the STL files as captured by the topography and moving the teeth, right? And sort of guessing where the bones of where the roots of the teeth are going to be, right? You don't really know because you can only kind of visualize, but you can be wrong because in central incisor, for example, the crown of the tooth is off by about 10 degrees to the root. So you could think the crown's a certain way, the root's at that angle. But there's another way to plan it out with Invisalign, and that's based off a cone beam CT scan. That cone beam CT scan is turned into an STL file, just the way the DICOM file from the cone beam turns into an STL file, just the way unapplied osteotomies are turned into an STL file. So the teeth are digitally moved to their final position, and based on that, a series of clear aligners are made, right?
Mm-hmm.
I can take a CT scan with the teeth in a very compensated position, either with spacing or sometimes with crowding, but certainly in compensated positions.
What do you mean when you say a compensated position? Can you explain what that means?
Yeah, that's a great question. So ideally, the teeth, I've got a funny joke to tell about this too. The teeth, the roots are along in the alveolar bone. Here is a big asymmetry. Mm-hmm. And the roots are centered in the bone. They're not tilted inwards. They're not tilted outwards, right? Why is that important? So
we're talking about the angle of the tooth.
Within the bone itself. Right, within the bone. So if the bones are not in the right position, the body will try and compensate for that by tilting the teeth such that the optimum biomechanical chewing ability is achieved. A typical example would be if you have a small lower jaw, you'll see the top teeth tilted backwards, right? And the bottom teeth flared forwards, right?
Right.
Orthodontic compensation and camouflage makes that even worse. That's what they do. I see people looking at like rabbits. The teeth are literally tilted backwards. It looks crazy. They lose their lip support. They smile. The mouth is this big, and the jaw is this big. Right? So ideally, just think biologically, it would make sense if the mouth would be matched the size of the jaws, right? So, but there's a mismatch. So why is decompensation important? Well, if you've ever hammered on a nail that's already bent, you're a builder. What happens to that nail?
It just bends in half, or it keeps
bends in more. Yeah. So if the teeth are not hitting along the long axis of the teeth, it's called axial forces. They tend to get more bent over.
Gets
right?
exacerbated. Yep.
It gets worse.
Yep.
So decompensation is putting the teeth in their correct position. Kareem told me a funny joke last night because he's just about ready for surgery. He said his orthodontist, Tom Rose, that's the other part of quality control, only working with orthodontists that I truck. So Dr. Rose is really good. He made my bite really bad quickly, meaning he decompensated the teeth really, really quickly. So
it's very telling, though, that he described it that way.
Exactly.
Because with decompensation, things get worse before they get better.
Exactly. That's a very common cause for misunderstanding. So
and then, of course, decompensation allows you to move the bones more. Or
yes, decompensation allows them to move them optimally.
Optimally, right.
Yeah, so ideally, I should be able to visualize something even if I'm going to do orthodontic decompensation, way in advance, like a year in advance, to know exactly where the teeth should be, because I've got a certain, and the orthodontist, me and the orthodontist have to work together. I've got there's a woman on my website, brown hair, big gummy smile. Her teeth are like up like this. There's like a 20-degree counterclockwise rotation on her. The teeth are like this. In the final plan, they're out at 15 degrees where they should be. The occlusal plane goes down from, 20 degrees to 4 degrees or something. But, the teeth are in the bone, right? Plus, sometimes you have to change the angulation of the teeth to get 130 degrees, what's called interincisal angle, by changing this premaxillary segment, So anyways, so the question you're asking me is, how do you do surgery first when you've got big compensations of the teeth? So I've got a model of I've got an STL file with the teeth in their present position, right? And I have, in the Invisalign scan, the alveolar bone, which houses the teeth, and the teeth in their final position, right? The alveolar bone can be digitally moved, but the teeth are in their final position when I'm planning the surgery. So I'm planning the surgery based on the final position of the teeth. That's how I know where to move the bones.
Oh, wow.
Does that make sense to you?
Yes, and you trust your orthodontist to be able to take care of the rest?
That is a great, great question. So I recently had a case where I didn't have a long working relationship with the orthodontist. The patient was from out of state. And I knew I could do it, and the patient was desperate to go to the operating room. And so we planned this out, and we were almost there. We took 5 sessions, and we still had one little step because you need 2 sets of STL files. You need a mandible with the teeth in a decompensated position and a mandible with the teeth in the original position. And you can't have them visually overlapping with one screen translucent or anything like that. You have to just see them exactly as they're going to be. And I had a conference call with the patient and the orthodontist, and I said to the orthodontist, if A is your best result, can you tell patient, we'll call him Jack or John, what your final outcome you could comfortably get? And he said, B minus. I didn't feel, I had confidence in my own surgical ability, but I didn't feel confident in the relationship, which is everything, because I didn't want any finger pointing. There were some things that the orthodontist wasn't getting. It was a complex case. The patient had what's called a Brody bite, and you had to get the top teeth from on the outside. You have to flip the teeth, and the only way you can do that is open up the bite slightly and do like this with the teeth. So because I have a good three-dimensional sense, I knew that that's how it could be done. And at that point, I withdrew from the relationship. So, but provided that I have an orthodontist that I can trust, there's a high degree of trust.
Right.
Then I will participate in those very difficult cases, because, I mean, there's my patients really are a lot of very, I don't say affluent, but very people in the tech industry, from Menlo Park, the Bay Area, all up and down the Eastern Seaboard, engineers, computer programs, people like yourself. They were once high functioning, and they're basically almost disabled. Like they're able to work maybe 2 hours, 3 hours a day. And it's sad, and they want their life back, and they don't want to go through distraction procedures. They don't want to go through pre-surgical orthodontics. They don't want to go through surgically facilitated orthodontic. They don't want to go through all that. They want to get on with their lives.
Yeah. SFOT was the last thing you were mentioning. Yeah.
Yeah,
It can be a brutal process.
Oh my gosh.
The hoops people will jump through to avoid surgery, and ironically, it's just other surgeries.
And people damage themselves. I see people over and over again. They are like, I call it, there's no parents at home. Like they're planning out, I think I'm going to have this procedure, then I have this procedure. I had a patient literally told me he was going to have some kind of distraction procedure on the maxilla. Then he was going to get orthodontic treatment, and the surgeon that did the distraction didn't do orthognathic surgery. Then he was going to come to me a year and a half later, and I said, it's not going to turn out well for you. I mean, you don't have the ability to kind of treatment plan. How much are you going to expand the maxilla? How much the teeth going to be decompensated? Do you realize that when you expand the maxilla, you're going to have an arch? You're going to have an arch width discrepancy. Even if you could expand it 6 millimeters, if the mandible is decompensated, you're going to have the maxilla 6 millimeters wider than the mandible. And if you're bimaxillary or retrusive, you're going to have to expand the width of the mandible. Like, how is all this stuff going to work? People don't really think it through.
Wow.
My heart goes out for them. And again, like I say, I see a lot of patients now that are coming to me that have had previous distraction procedures of the maxilla. They still can't breathe. And so we got to expand the maxilla more. Yeah. But that means we have to expand we have to expand the mandible, or start compensating, putting you into what's called a reverse. We have to put you in a reverse curve of Wilson, and tilt the teeth out, which is even more, it's just geometry and stability. People don't understand the biomechanics, biomedical engineering, sequencing. This is a complex subject, and my heart goes out to people that spend decades and tens of thousands of dollars and actually cause a lot of damage to not only their psyche, but their dental alveolar structures and their pocketbooks and their loved ones. Yeah,
you're looking at one of them.
I've got so much compassion for these people, because it's so hard to negotiate, to figure out, I'm so sorry that happened to you. And I'm so sorry that people don't have better solutions. We just kind of, it says on my website, focus on understanding your needs and, solutions. My email address, as you know, says solutions at Orthognathic Surgery, not info, solutions. Because my patients are my teachers, and they teach me, they are inviting me to come up with solutions to better their lives.
Yeah. I mean, I'm personally at a point where there's two reasonable treatment options on the table to my eye.
I see.
And that's jaw surgery and maybe these naso-maxillary expanders for someone who's not ready to take the plunge.
Mm-hmm.
But you're saying that your way of doing the jaw surgery makes naso-maxillary expansion totally unnecessary specifically for nasal breathing improvement, because some people do get nasal breathing benefit from the MARPEs, right?
Yes.
But there's always a great risk involved, specifically these leveling issues, the asymmetry issues, and then of course, unless you're willing to do another surgery for the mandible, specifically, SFOT or an MSDO, or you're going to be limiting the magnitude of the maxillary expansion unless you're willing to do some kind of surgery on the mandible.
Unless you're willing to put compensations. You've got like, now are you talking to me as a patient, or we're just talking about the general problem? There is, it doesn't really matter.
Both.
If your arch widths are coincident right now, the width of your arch, your maxillary arch, and the mandibular arch are coincident. There's no what we call arch width discrepancy, right?
Yeah, at the skeletal, not dental, right? We're talking at the bone.
Skeletal, yeah. So the teeth, as I understand you just say, the teeth they're decompensated. The roots are in the bone. And your arch widths are coincident. I mean, there's an easy way for me to tell, a clinically way to tell. If you just smile, I can look at the width of your mouth and see the width of your clinically.
I'm a disaster, by the way.
You don't have to do that. Don't even do that. Just smile. Just smile. Take your fingers out. Look at the width of your mouth. It's not bad, but I can see. You can relax. I can see you've got wide buccal corridors, what we call wide buccal. You got these black tunnels, right?
Yeah.
Right. That could be for two different reasons. It could be because both jaws are too far back, and when you bring things forward, the wider part comes forward, or you're narrow. But symptomatically, you still suffer from upper airway resistance syndrome. Am I?
Oh, I definitely do. I still have a lot of headache symptoms constantly, pain at the back of my neck. Waking up, I snore. My wife, whenever she sees me on my back, she wakes me up because she knows that if I don't turn onto my side, I could end up waking up with a headache.
Well, forget about what about a sudden cardiac arrhythmia because lack of oxygen to your brain?
Yeah.
What about impaired executive functioning? When was the last time you had a dream?
Sometimes I have good nights, sometimes I have bad nights. But it's hard for me to work more than 3 hours a day, to be honest with you. I have a hard time getting comfortable enough in my body to work. Right now, I have a bit of a headache, to be honest with you.
You said it beautifully. I have, because it's an embodied sense.
Yeah.
I have a hard time getting comfortable, and that could be because that could mean a lot of things, but it's a felt sense, right?
It is definitely a felt sense.
It's a felt sense, right? So if the width of your upper jaw and your lower jaw are coincident, and it looks like you've got a good bite, and you still can't breathe through your nose, you need more oxygen. What about the size of your airway? Do you know what that is? How many?
Yeah, it's not great. I don't know exactly what it is, but I believe. So are you asking how am I in the A?
No, from the level of your tongue downwards, between your tongue and the top of your larynx, or your vocal, the top of your larynx, because the top of your larynx is a fixed width, right? Right.
Yeah.
So
I don't think it's good. I believe that's where my problem is. I believe that my jaws need to come forward, and I'll just show you what that looks like. But
yeah, I can see that. Yeah. So plus you're in a head forward position, by the way, Ron.
I mean, I agree.
The top of your cranium is not over your shoulders, right? If I look at you in profile, the center of mass of your cranium should be over the head of your humerus.
And where is it? Yeah. What are you seeing in me? Could you exaggerate what my head looks like? Am I like this? Am I jutting my chin forward?
Turn to the side again. Turn to the side. Yeah. So you have the typical, I would say, military neck. It's hard for me to sort of copy it because But if I were to go, it's really hard for me to do it but your head's forward, but it's not hyperextended, right? It's just forward, and you've lost the concavity at the back of your C-spine. So the wear facets at the front of your vertebrae are, they're supposed to be stacked. If I look at your C-spine, you'd probably see less space up front and more space at back, right?
Yeah.
And I've seen cases where they're actually in a reverse curve instead of concave backwards. Like I say, the most common is your pattern, which is military neck. The second most common is an exaggerated curve, right? And the third one is a reverse curve. So you have the most common pattern. But I can clearly see the center of mass of your head is not over the top of your humerus, right? Which is not over the top of your femur, which is not top on your knee, the bottom of your tibia, and your calcaneus. So my heart goes out to you, and thank you for asking me my opinion, I suppose.
Yeah. Do you find that patients who present like me with constant pain and sort of instability at the back of their neck and tension, waking up with tension and pain at the back of their head and like sort of craniofacial muscular tension, do they improve with jaw surgery? Like, I'm trying to determine if maybe that's really what I need, or maybe I'm just handicapped and like I'm just fucked for the rest of my life with this condition, and there's really nothing I can do about it, and I just have to learn to live with it.
Maybe we should read some reviews of patients. Don't trust what David Bell says. My patients they rate literally. It's humbling, whole essays. But it kind of, so the answer to your question, it depends on what condition they come in with.
Right.
I mentioned to a patient there was a yoga practitioner. She was in constant pain. She didn't have much strength, and her weight training ability increased dramatically, and the pain just went away.
Was it pain in the neck?
It was actually all day down back, all the way down to the soles of her feet. That entire, what we call the posterior chain. I talked about her before.
Yeah.
You can see her posts on Reddit. Says animal medicine.
Okay.
Animal medicine. Yeah. There's another patient who is in the medical field, a triathlete. In medical field, triathlete, severe obstructive sleep apnea, condyles gone, gone, falling asleep at work all the time, dramatic difference very quickly. It kind of depends on people's level of conditioning and their attunement to their body to begin with. Sometimes I see people with complete elimination of dissociation, a lot of stress-related illnesses like, say, for example, hives, headaches, musculoskeletal problems, immune problems, all stress-related, trauma-related. It depends on sort of what adverse life events they come in with. So those can be different type of trauma wounds, like anything from neglect, abandonment, gaslighting, disenfranchisement, like what would they call little t's, just by appearance.
Yeah.
Teasing children are notorious for playground teasing. They're bullying, online bullying. It really depends on what type of trauma wounds they come in with and what kind of support they have afterwards, and which is so important for my practice to be able to have the resources to send them to trauma experts who themselves have recovered from trauma. One of my best friends has been in 4 special forces, like black ops, right? Like off the chart. Yeah, and we talked a lot about this. He's in the mental health field, and we talk about these kind of issues in healing of the mind-body system and these embodied trauma wounds that's expressed as immune dysfunctions, musculoskeletal problems, you name it. Lack of social, lack of emotional connections, lots of trusting relationships. This planet is so much in need of healing, my friend.
Yeah.
It's staggering, and there's a lot of unnecessary suffering. The one thing that will empower people is information.
Mm-hmm.
It will empower them and know they're being heard. When we feel seen, heard, understood, or at least accepted, we do so much better. Sometimes people can't even express what they're feeling. I'll ask people, what are you feeling? They tell me how their day went. Like, are you feeling stressed? Are you feeling happy, elated? Are you excited? Are you feeling jealous? Are you feeling, you ask most people to describe their emotions, they have about 3 words. Brene Brown has written extensively about this in her brilliant book. I think it's called Map of the Heart. If you know who Brene Brown is.
No, I don't, but that's interesting.
Vulnerability and courage, which are related, right? If you can't act in the context of fear, how could you say you have courage, right?
Yeah.
Right.
That is courage.
They go hand in hand.
Yeah.
To be able to act. And you, my friend, have shown courage just by your vulnerability and disclosing to me your story and your current problems.
Well, I want help. I need to fix this, man. I have a family. I need to be able to work more. I have a mortgage. It's not, I can't just lounge around all day massaging my neck. You know what I mean?
Right.
I'm past that point, so.
We rescheduled this meeting. You said, well, my family just moved. My daughter's going to a new school, I believe you said.
My daughter's only 9 months old, but
okay.
Yeah.
I know you have a new daughter. Yeah, that's right. You had a new daughter.
My wife is pregnant with the second.
Whoa. So the stress is on.
You
might feel like the walls are closing in on you.
They are. They really are. Yeah, for sure.
And then the question becomes, well, do I keep on just hammering it out here, or do I get this fixed? And if not now, when? And that uncertainty will eat your lunch, and your wife's lunch, and your child's lunch, and your unborn child's lunch. Because with these high adrenaline, if you're dysregulated, your wife's going to be dysregulated unless she is able to completely regulate herself. But she's a Marine.
Sailor, but yeah, same idea, yeah. But she's tough as a cookie, but nothing upsets her more than seeing me not feeling well,
So you have a responsibility to yourself to be responsible to your wife. I read a book 30 years ago that changed my life called The 7 Habits of Highly Effective People. My friend, who's been in 4 special forces, was the international spokesperson for that person, as well as, a lot of coaching for So in that book by Stephen Covey, It Changed My Life, he quoted the head of the United Nations, who said, it is far better to be loyal to the one rather than to be loyal to the masses, because you can't be loyal to everybody, right?
Right.
I used to think that meant to one person, and my friend worked with Stephen Covey's son for the Franklin Covey organization. And he said his son, Stephen Covey's son, said, the one is the self. Loyalty to the self. Self-trust allows others to trust us. Self-compassion allows us to have compassion. Self-forgiveness, self-love. That's why on my website on Reddit, it says there's a t-shirt that says choose love. I mean, that is an important concept. So I invite you to go inward and be loyal to yourself and figure out what is best for you and your family.
Yeah, I mean, I just don't know what that is. I've been in orthodontics for 8 years and 1 month now I had several botched treatments.
Wow.
And so and then finally, a naso-maxillary expansion that was decent. At least it gave me quite a bit more tongue space and helped me breathe significantly better through my nose. But there was a lot of orthodontic fallout from that, it's been 5 years of orthodontics since that. So believe me, I know what you're talking about when you talk about these expanders sort of being, the disease being worse than the cure, or the cure being worse than the disease. But so it's like if I go and spend a bunch of money on this surgery and take a month off from my life to do this and whatever, and it doesn't work, it's just like that's just too much. So
of course.
It's not like I'm new to this space and I'm going to make that right decision where I don't do the stupid orthodontic thing and I go right to surgery. It's like I'm in year 9 right now. So if this would just be absurd for me to do one more wrong thing to my face. It would almost be insane, right? After 8 years to now do the most extreme thing, hoping that finally something is going to give.
So I want to ask you a personal question. Are you feel comfortable asking this? Like do you have these discussions with other surgeons or other people that are on this show?
Not really. I ask everyone I talk to, every surgeon I talk to, I ask if they think I'm a candidate for surgery. and then
how do they, well, there's so many ways to answer that question, right? So it requires just sort of me understanding what's going on in your life, right? That's where I'm starting, right?
Right.
And then review of your records.
Yeah.
So I'm happy to, I would be honored, I'd be thrilled to, if you have current records, for me to review them.
No, I appreciate that.
Yeah, I mean, it's, this is your loyalty to yourself, your loyalty to your wife, your 9-month-old infant, and your unborn child. You got a lot. I mean, we got a lot on the line. And I can imagine how that could be really overwhelming, like just, that's that vagal shutdown, right? Frozen. I don't know what to do. But you also told me something about yourself, and this means different things to different people, is that you are more motivated by what you want than by what you fear. I find a lot of people, myself at too, and as I've been through traumatic experiences in my own life, where it's like the time just went away, like I was just completely shut down. And it took a lot of being still and having trusting relationships and people who had recovered from their own trauma to help me navigate my way out of this. It's a journey. It's truly a journey. And it's a story. It's a life story. You're telling me basically your life story, which you are writing. In every, it's been said that in every great novel, you see this in the Bible. If you've ever seen the movie where the crawdads sing, like they chronicle people's entire lives, their life's journey. And it can be a nightmare or it can be, an adventure with, funny things and scary things. And guess what? At the end, everything turns out fine. But we have our biologic heritage is to be, we have a highly tuned fear, protection system. The interesting thing about this is a lot of times people never make a decision out of fear. It's almost like, what if I'm afraid of tripping over that paver because it's sitting like inches high? I'm hyper-focused with my face on the glass without considering I got a 5-mile journey down the sidewalk. I could trip on another paver. But because I'm afraid of that paver right there, I'm not even going to take it for the first step. So I'm a big fan of, my friend has a Lakota Indian heritage, which are the people that grew up near where I grew up. And there is a line in a book that I read by the man who wrote one of the books. So if you climb a mountain, what is the most important step? Is it the first step? What's the most important step to get up that mountain?
The next step.
The next step. Every step. Exactly. And you know what the name of that book is?
Step by step.
Keep going, the art of perseverance. So you have shown perseverance. You've told me so much of your story. It's an honor to hear it. It's been an extraordinary conversation because I rarely have people. Well, I've never been interviewed before. So the fact that you are having this conversation with me is really something.
Yeah. Well, you strike me as someone who could help. So obviously, and today this past 2 weeks has been particularly awful for me. I mean, to the point where just like the headache frequency, essentially, to the point where, I ditched all nicotine, obviously, because that's got to go. And now I quit coffee too, because I haven't been at that point since 2019, when was the last time I quit coffee.
Yeah.
So I'm like quitting caffeine to just doing anything I can to try to just get my system to just calm down a little bit, Yeah. And even my wife said to me for the first time about a month ago, she said, maybe you should consider jaw surgery, which a year ago, she said, if you ever get jaw surgery, I'll kill you, because she's scared of it and she doesn't want me to look different. Now she's the one saying, maybe you should consider it because she sees what I'm going through.
I always, encourage people to come out with their loved ones for consultations. So it's because the fear of loved ones or the misinformation is like, I could see how parts of you could be torn. We all have parts, right? A part of you wants to be, and she has parts too. She cares. She truly cares about you. She thinks you're a handsome man. Probably thinks you look hot or whatever. But she's scared. So, and you with her too. It makes so much sense that both of you would be at this crossroads, this dilemma in your life.
Yeah.
And if it were me, I really try and avoid giving advice. I prefer to say, if it was me, I would enter into a conversation with someone like me or someone else that you might trust, and bring in some records and start a conversation, which we've started that conversation now. And or invite her to watch this before. Are you going to put this in segments on the internet or whatever, or in your podcast?
Yeah, I'll probably do a full interview and then post multiple small segments as well.
What's the time course for that? Just until you've edited it and stuff like that?
You mean how long until it's posted?
Yeah.
Oh, this probably 4 to 6 weeks.
4 to 6 weeks, yeah.
Yeah.
Is there anything else that you want to talk about right now?
We're breaking 3 hours, 20 minutes. Yeah. I mean, I have a lot more that I would like to ask, but
sure.
You want to do like a rapid fire segment? Or rather do maybe another interview in the future?
I'm good with a rapid fire segment. Yeah, okay. As long as you are.
Yeah, I'm good. Why don't we plan on going another 20 minutes rapid fire?
I love that.
Okay.
Yeah.
Oh God, but these questions are not suitable for rapid fire. I mean, my first one here is, what are the benefits of custom plates as opposed to non-custom plates, and do non-custom plates actually have any advantages to custom plates?
Great question. Okay, so I can do much more complex geometric movements with custom plates, right? I would never consider doing a 5 or 6 piece mandible with regular plates, because I would have to, first of all, it wouldn't be accurate. I would have to wire someone shut for 6 weeks or 2 months. In my hands, there's simply things I would never consider doing otherwise. Mm-hmm. I would not, for short face syndrome, I could literally drop a maxilla like 5 mils or reinforced 7 millimeters, like have it hanging in space and graft all the way back to the pterygoid plates. I would never consider doing that without custom plates. Complex, when you do a 5-piece mandible, you have to take, it's widening like this, right? And also going out like that at the bottom. Those are complex movements. And, 6-piece mandible without, it's like, I would never do it.
Yeah.
But it has to be done. It has to be bioengineered correctly. Plus, I always know I know I can control the trajectory of the screws and make them divergent, right? And there has to be a match between the rigidity of the plate. These plates are like rigid, especially with a double bar construction at the top. It doesn't rotate, right? Mm-hmm. I could even put a double bar down there. But these things are this is heavy duty girders and construction material. But not everyone uses them that way. Some people just use them the minimal amount. They use 6 screws. They're using monocortical screws, or they're 6 millimeter screws. They're not using 12 millimeter screws. They're not using 16 screws on the mandible. They're not doing these complex things. Mm-hmm. They're not coming up with these kind of solutions. It'll just allows the disadvantage. It's expensive as shit. It really is expensive. Yeah. It's really half the cost of the surgery that I perform is tied up in the technology.
Wow.
Yeah. So, and also that just the way I do it, I get before and after models for every single case, because I want and need that kind of safety for myself, so that I can provide that safety and predictability for my patients.
And what does the model allow? What safety does that provide? You can test the plates on the model to make sure it all fits?
Well, I don't know if you notice here. Do you see it's etched? I know exactly how it fits, right?
Yes.
On the model, right?
Yes.
So that's the first thing. The other thing, if I'm doing surgery first, I'm putting screws in between the roots of the teeth, right? I need to know which way to angle those screws where the teeth are. If I'm putting screws here, I want to know where the nerve is. I can see. Can you see the nerve?
Yes.
So I want to know does it look like the model? Because it should look exactly like the model. Mm-hmm. After, the fit of the guides on the bone should look exactly like this. This stuff is so accurate when you get the kind of CTs that I get. It's just like like it used to be that the CTs were more accurate, or there was a mismatch between the accuracy of the fit. But when they call the stuff true match, brother, it is a true match. It just sits there perfectly, passively. Yeah, that's the other thing. You have to mobilize the soft tissue. Everything has to be as passive as possible. And that even has to do with the nervous system, because you got stuff. The only thing that's going to be under high degree of tension is going to be the musculature underneath here on the hyoid bone. You saw that on the GIF. The guy's hyoid bone went up, like way forward like that. I don't know if you noticed that, but it's the engineering when it's used with skill, and I'm willing to push those limits. The beautiful thing about all this, Ron, is that it's this very, very high-tech thing that I am doing to create this very human experience for people. You cannot parse out the two of them. They are so related. And the extraordinary dedication of people like you, the biomedical engineers that I work with, Kareem, Lauren, the orthodontists that I work with. I mean, we truly care. We're not doing this to make, there's easier ways to make a living, believe me.
Yeah.
I didn't choose this life. This life chose this for me. Yeah.
I can say the same for myself.
Yeah. And put the words exactly out of my mouth. I know that.
And thank you for that explanation. Do you do the maxilla first or the mandible first, or does it depend?
Mandible first. That's a great question. So I want to put the mandible against something that is totally rigid and immobile, not something I've just cut on, right? And if you speak with the engineers or the misinformation from people, I've been doing mandible surgery first for years. Why? Let's just say I'm positioning, let's say I wasn't using custom hardware and I would want to position the maxilla. Well, the mandible doesn't always swing symmetrically. It can swing off to the side, right? So if I'm changing the vertical position of the maxilla, I could put it on a cant or off center. That's the first thing, right? The second thing is when the sequence with which I do it is I put 3 screws in this middle piece, right? And then I put 2 screws snugly, but not...
Yep, you're a little out of frame, yep.
Yeah. Let me show you with a plate. So I put... are you there?
Yes, I'm here, yep. I just put you in solo view so that we could see more of the object.
So there's 3 screws in that middle piece, right? Then I will establish the width by putting a screw out here. I think it's backwards. And there, snugly but not loosely, right? Then it goes into an intermediate splint. Where's my intermediate splint? Somewhere around here. I can't show it to you because... so the intermediate splint puts, and I wire everything together. And I literally have an assistant pushing up with their fist, with their elbow, right beside to stabilize and jam those teeth, the teeth right into that intermediate splint, because it's an uncut maxilla, to make sure the bite is dead on. Only then do I start tightening screws. Does that make sense?
Yeah.
So I know the bite's going to be right. Have you ever changed I'm sure you have. That's a rhetorical question. Have you ever changed a tire on a car, right?
I used to be an auto mechanic, so yes,
okay.
Many times.
Do you tighten one leg all the way?
No, you tighten them all a little bit, and then you drive them home diagonally.
That's how you do it.
At least that's how I did it, because I'm OCD. The other guys were just slamming them with the air gun. They were mostly hacks, though. Yeah. So it'll never be right? Because 1/4 millimeters, you have to incrementally balance out the forces, right? Correct.
So you have to make sure the bite is dead on. You have to make sure everything is compressed. And you can't put on those kind of forces with like a freshly cut maxilla, right?
Right.
You'll just tear the whole thing off, right? Like you're bringing the jaw way, way forward and you're widening it. You need these extraordinary forces to do that. And so and you'll know if it's right because once you cut those wires, the maxilla should swing, the mandible should swing right into the spine. And it does. So mandible first.
Okay.
I would want to use a lot of force and make sure it is dead on. Incidentally, as good as the bite is when it's planned, within about 2 weeks, it's always better. It's always better.
Amazing.
Yeah. Mandible first.
Mandible first. Thank you. Do you, if a patient wanted you to remove the plates after surgery at some point in the future, would you do it? How do you feel about that? And when would you do it? 6 months, 12 months, 18 months?
So first of all, it's based on biology, always based on biology and based on their healing. If there is if they haven't reached an endpoint in the return of their sensation, and sometimes people are on a kind of a slow course. Sometimes a lot of people that have got, say, 50% sensation at 6 months, you see them at a year, 95% sensation. So they have to reach an endpoint for their return of sensation or return of certain biologic markers, which also inform my follow-up schedule.
Is that mostly on the lower that it takes that long for the sensation to come back? The upper usually comes back online first. Is that true?
Correct. Right. Yes. Yeah. Almost always. Right. And so then I had to get a CT scan to make sure there's enough overlap between the proximal and distal segments here. Right. Typically, you can't really extend beyond about 16 or 17 millimeters. Right. You can see that the treatment plan for that blonde lady online at one side was about 17 millimeters, right?
And then the rest of the 2 centimeter at the gonion, at the pagonion here is genio. Is that right? So you can do so much separation,
yes.
and the rest is made up for at the chin, right?
Yes, and plus the counterclockwise rotation. Well, the overlap, but the more when you do a counterclockwise rotation, it swings forward. I can show a screen here someone asked me what was the maximum. Let me show a screen on Reddit, and I'll show you an example of a 29 millimeter advancement, some with no condyles. Let's see, present, share screen. This, okay. This is a patient, by the way, after a probably 10 or 12 millimeter maxillary advancement, and his chin coming forward about. That's my 3D MD scanner, by the way. That's showing like the sidewalls of the mandible there, like how much you're expanding the nasal vault. That's about a 15 millimeters transverse expansion of the max. So look how high up it's cut, right? So I'm capturing so much of the sidewalls. And
is that really the key to getting improved nasal breathing with surgery?
Absolutely. Yeah. If you cut it down here, look at that. How are you going to capture the sidewalls of the maxilla or the nose? Yeah, it's impossible. You just be making the maxilla wider. So here, a lot of good questions here. So here, I have a few questions. What was your biggest begonia movement? Are there upper limits? Can mouth become wider from palate expansion and Lefort one, especially so as the gummy smile? So say, I'm not sure what the all-time record was. I would have to go to my records. I know I performed a surgery in the past year where there's a 29 millimeter advancement. You're probably going to lose the screen here, so I'm going to have to Okay, so no condyles here, right? Look at this.
Mm-hmm. Mm-hmm.
Huge counterclockwise rotation. The gaps here are, that's 15 on that side, 15 on there. Pagonian, POG, 28.8, right? So, and this was huge counterclockwise rotation.
Mm-hmm.
Um,
And you were saying this is about the maximum that you can go at the BSSO cut.
well, look at the overlap here. So your question to me, and the patient wants to know this too. Sometimes you can get a little bit of concavity in here, like if you view from the side, it can look like it's depressed there. Hers, surprisingly, no, because of the design of the plate. But she wanted psychologically, so I said, well, we have to take a look at it. And that plate, which has probably 17 screws, if there's any question, I will take that plate and cut it down, like literally take it out of her mouth, take out the plate, and cut it so it's like a box, right?
Mm-hmm.
And graft in there, just so that it maintains the advancement and there's no rotation, there's no torquing between this piece, like this piece and this piece. Does that make sense?
Yeah.
In the maxilla, pretty much the same thing. The indications there are psychological, maybe, or if I want to create more volume in the midface below the malar prominence. I used to do all the grafting at the same time. But there is a higher infection rate if you do the grafting at the same time. And so that's why I do it this way. But and there's different ways to graft, right?
Oh, what?
So that's your question.
Yeah, I'm not sure I understood that when you said you used to do all the grafting at the same time.
Okay, so right. So the mandible is half the thickness here. You understand that, right?
Yes.
Right. So cosmetically, one could develop a sort of concavity in this area. Just when you look at the skin, it could look like it's not full.
Right.
Right. So what's the workaround? You either build up the volume at the same time of the surgery or afterwards. To a certain... Mm-hmm.
So you're saying you'll literally go in for a second procedure to add more grafting material to that spot in a second procedure?
It depends on what the wishes of the patients are and what the goal is. Okay. There's no one way to do it. But it's not a big thing to take out. Hardware removal is a very quick procedure.
Mm-hmm.
So, again, my relationships with patients are their dialogues. They're not monologues by David Bell. It's just not like, it's a conversation. It really depends on what they want, what their goals are. Let me stop sharing this. And, what's important to them.
Mm-hmm. Mm-hmm.
And, but I have my own boundaries. I won't participate in something that I don't feel comfortable with, that I think that the patients can't really think through the potential risk to them.
Right.
Like I had to protect people from making poor choices.
Of course.
Yeah.
They're allowed a certain amount of autonomy in choosing their treatment, but within boundaries. Within
boundaries, yes. But it's always, but if they don't want me to bring their max, I had a thing, I thought a patient that another well-known surgeon said, well, you have to bring your upper jaw forward 15 millimeters to improve your airway. Had a previous distraction of the maxilla. I said, I don't think 15. I said, I recommend like 10 or 10, 11. He felt comfortable with 8. I said, fine, let's do 8. His airway is 400 square millimeters.
Right.
Yeah. So that's the answer to the hardware removal.
Thank you.
Yeah.
And to piggyback off something you just said, I have a friend and client who has done the rounds, seeing a few different surgeons, And
I've probably spoken with them.
maybe you have.
They all contact me.
Maybe you have. And
Yeah.
he has, so for example, one surgeon recommending a 7 millimeter mandibular advancement and another one recommending 14 millimeters. Same surgeon, same patient. How do you get that level of discrepancy in surgical plans from top tier surgeons? And as a follow-up question, do you agree?
Yeah.
Do you think that the 7 and the 14 millimeter advancements would be different with respect to the airway improvement?
Yes. So someone asked me a question recently on Reddit. How do you know that the airway is going to be bigger? Well, it's just physics and physiology. It's described in mathematical terms. And one of the parameters uses a part of the equation. It's called the Bernoulli flow equation. So fluid dynamics and airway dynamics are very similar. But you must remember from geometry pi r squared, right? Mm-hmm. It's the area of a circle. Well, the airway isn't exactly a circle. Well, with me, it's more of a circle. With most people, it's an oval. But so the flow through the airway is proportional to the cross-sectional area. So if you, let's say the airway is 10 millimeters from front to back, or, the minimum should be 11 at the level of the angle of the mandible. So if you just punch in the numbers, it's the square of the diameter. So it will be bigger. Yes, absolutely. Mm-hmm.
But that doesn't always translate to an experienced benefit by the patient. Is that right?
Depends on where it depends on where, if there's it depends on whether they're nose breathing or mouth breathing, okay? Right. So if they're mouth breathing, it will, as long as they're using proper, like body mechanics. Most people do not breathe properly. They don't breathe from the diaphragm. They're kind of doing these shallow upper, like with their things. So the lungs should fill from the bottom up and come down. But in terms of airflow, it's there's no reason why the airflow should not improve. And when I say exponentially, I'm really meaning it literally, because that's what the formula yields. It's pi r squared, right? Mm-hmm. So here's where the catch is, and I think I know what your follow-up, I could kind of feel your follow-up coming to me, was why would surgeons plan it out two different ways, okay? Was that going to be, I'm reading your mind. Yeah.
That's the key question, yeah.
Yeah,
ultimately, this patient needs to decide, should they go with the 14 millimeter or the 7 millimeter advancement?
Right. So a patient asked me that question recently he went to another well-known surgeon that's got a high volume practice. Well-known, they have people coming from they do simple surgeries, one-piece maxillas. They do stuff that is quick, about the same profit margin as, I suppose, as mine, but they're not complex surgeries, and they use them with regular hardware. Even people.
What do you mean regular hardware? Non-custom?
Non-custom hardware. And even when people do use custom hardware, a lot of them are I'm not even sure why you're using it for accuracy, maybe you're for speed. But if it's not planned, when a person needs a segmental forward osteotomy and they do a one-piece maxilla, it's like, really? How stable is that going to be? And then you're going to start decompensating the teeth. You're not going to treat the upper airway resistance syndrome. Like, I just don't get it. So why do people do it? I don't know. People do things for a lot of things wrong. I don't know why they do it. It doesn't make sense to people, and it doesn't make sense to patients. And that's why we're having this discussion.
Yeah.
Because it's like, does that really make sense?
Yeah. So did we answer the question of how do we get from 7 to 14? It's just an arbitrary thing between surgeons?
You had a two-part question.
Yeah, right.
One, can you expect more airflow? The answer is yes.
Yes, right? Of course. Yep.
Yeah. Now, is it 7 more mirrors with a linear turning from a circle to an oval, or is it a radial expansion like I do?
Right.
So there's a big difference there, a huge difference, right? So, but you will get it.
Yes.
The second question is, why would there be that discrepancy? Surgeons wanting to do a lot of cases, do them quickly, be scared of condylar resorption. I mean, are we talking about two surgeons both using custom hardware? Or
No. No.
Yeah.
Two surgeons not using custom hardware, I believe.
Yeah. So, so 14 millimeters, depends on how big the gap is and how rigid it is. So you can do that, but that's pushing it without custom hardware.
Right.
And the micromotion, even if you put what's called bicortical screws, like you put screws, I put bicortical screws up here, went through both the outside piece, so there's rigidity up there. There's a lot of three-dimensional rigidity, like it's like a box, it's like a cage.
Right.
But even with that, bicortical screws and a plate, which is a fairly, like a plate or just bicortical screws, you're still going to get, you don't really have a box-like construct that can't, twist and turn, right? So I suppose the only way you could do that, well, you can't, if you swing this piece up here, you can put screws at the top and create a box, but then you're changing the resting muscle length. That's why I leave them, and it doesn't look as, the resting muscle length, there's a length tension curve for a muscle. You're changing the resting muscle length, and also you don't get as good cosmetic results because then you've got this stape angle rather than keeping that down and having a nice linear jawline.
Right. Right.
So I think I hope I answered your question.
Yeah, no, you did. Thank you. How do you account for the skin at the roof of your mouth when you do the multi-piece segmental wide?
Great question. I'm giving away all my secrets now. How do you expand a maxilla 15 millimeters? Is that what you're asking me?
Yes.
Great question. I rarely get asked that question, but it's a great one. So what's a good way to explain this? I'll be back in 1 second.
Okay.
Okay. I thought I was going to give you a tour of my home, but that'll be for another conversation. I'll have that with Alexia?
Alexis.
No. Alexis, yeah.
Yeah, she's Greek.
Okay. Right. So here's a string, right?
Okay.
Right? This is the roof of your mouth upside down, right?
Okay, yep.
What happens when I go like this? It gets longer and wider, right?
Yes.
Okay. Now, there's two types of tissue inside your mouth. There is movable tissue, otherwise known as mucosa. That's what forms the inside of your cheek, right?
Mm-hmm.
And there's gingiva, which is that stippled stuff, which is like a coral pink color when it's healthy, and that's stuck to the bone, right?
That's like what's at the roof of your mouth?
Yes.
Yes.
So your question, which is a very good one, how do you expand the maxilla when the tissue won't stretch, right?
Correct. That's it. Exactly. Yes.
Exactly. And you've seen the pictures that I put on Reddit where you see me expanding the maxilla 10, 15 millimeters, right?
Yeah.
Yeah. So how do you do that? Okay. So there's a couple. The most important thing is that tissue, you have to make, I would have to show you pictures. It's better explained with a picture. Okay. Are you looking at an Adobe document right now?
Yes. I'm looking at an Explorer window.
Okay.
Yes. Now I'm looking at
okay, right. Okay.
like a slideshow. Yep.
Yeah. So indications for expansion, an arch length deficiency, you know what that term means now. An arch width deficiency. Arch length is when there's crowding, and one is for arch. So we're talking about arch width discrepancy in the context of just doing a single piece large expansion of the maxilla because it's narrower than the mandible. Okay, so how do we evaluate it? Well, I'll leave off all this stuff because I'll be confusing. So the way you do it, do you see these lines here? The red line here. Mm-hmm. So when I didn't draw it perfectly good, and this is ages old. So normally when I do a segmental maxilla three-piece, which 90% of my whole life I've maybe done less than 10 single-piece maxillas. Either because you want to coordinate the arches better or because they need to be expanded. So normally I'm doing 4 pieces. I make a cut here, right? And like this red thing over here, and a cut here and a cut over here, because maybe there's only about 6 millimeters of expansion, and I can, maybe 3 millimeters there, and that's very stable, okay? But if I want to do it 10, 12, 15 millimeters, I have to come up with a different tactic. So I make an incision up here along this blue line, right? And I tunnel under the whole thing, right? Mm-hmm. I'm literally crossing the midline, and this stuff is just non-adherent, right? Then I make the cut here, and the cut here, and I make the cut in the bone here and over here, which is a mile away. This is like 20 millimeters away from this line over here, between the cut here and the cut in the bone. So why is that important? Because if I don't do that, the patient's going to get what's called a oral antral fistula. There'll be water going from this incision and into their nose. You get it? Mm-hmm. So that is the magnitude of that expansion. That's about a 15 millimeters, right? Mm-hmm. Here is the patient's bite.
So the way
it's a little bit wide, actually. You can see that canine seam a little bit wide, right? There's the other side. That a little bit better. Excellent orthodontist, by the way. Do you see all these bends in this arch wire? Mm-hmm. Most orthodontists don't know how to do this. This is a rectangular arch wire. His name is David Sparks. He is in Cerritos, California.
Is he your go-to?
I don't work as much with Dr. Sparks anymore because of not having anything to do with his skill, just a little bit for more logistical reasons. But I've probably done at least 50, 60 cases with Dave Sparks. Great orthodontist.
Yeah, he sounds amazing. Can you go back to the previous slide before that one?
But there.
Nope, next. Nope, before the one that shows the actual cuts in the model.
Yeah, here.
The next one.
There.
Yes.
Yeah.
So you're doing these segmentals in such a way that you don't get big diastemas in the teeth. Is that right? This is all happening kind of like...
Look at it. That isn't a big diastema in the teeth. There's a little bit of space there, right?
Right, but not much.
Look at the point of rotation. By the way, it's in actually 4 pieces. But for the sake of this company, they diagoned it. It doesn't matter. The teeth are the width is the same. Whether they made a paste like this, and it's immaterial for the course of the overall geometry. But yeah, no, there's sometimes there is a little bit diastema. It depends on whether the patient has. Well, sometimes we've got narrow lateral incisors. Or sometimes there's what's called a tooth mass discrepancy, where the combined width of the lower 6 teeth is discrepant between the width of the top teeth, in which case you've got 2 choices. Either you can leave spaces in the upper teeth, put a veneers or composites on there, or do what's called interproximal slenderizing on the bottom. So let me go to this thing over here. So let's say there was big spaces there, right? Mm-hmm. It's good to know that beforehand, because then you could take off a little bit of enamel. You've got 10 surfaces, 1, 2, 3, 4, 5, 6. As long as the teeth are V-shaped, the lower teeth, you can take off 0.5 millimeter, and you can actually get up to 5 millimeters of interproximal slenderizing on the bottom teeth and bring the 2 lower canines in. That's you wouldn't want to do that, but like 2 millimeters may be okay. Other option would just be leave a little bit of space, make these teeth wider. So that's how you get a big transverse expansion of the maxilla.
And if you go back to the model that has the blue and the red lines on it,
Let me share again.
Did those? Why were some lines blue and some lines red? Did that indicate cuts in the skin versus cuts in the bone?
Yeah, let me explain that one more time. I kind of went over it fast. So if I'm doing a standard expansion, then I'm not making cuts on the palate. I'm just making an H like this in red.
Mm-hmm.
That's the cuts of the bone.
Mm-hmm.
If I'm doing a big, huge expansion, I'm making an incision in the gums up here, way up there in the gums. Right?
Mm-hmm.
And I'm tunneling underneath here.
To the bone cuts.
I haven't even made the bone cuts yet. It's like the very first thing I do in the operation.
Then what's the tunneling? What do you mean when you say tunneling?
So what is a tunnel? So there's a, let me close this window and I will show you, I'll get a model. Let me get a model. This is called a freer instrument. See, it's got a curve there,
Mm-hmm.
right? So I put this instrument up here and I'm tunneling underneath that. You can think of this, the tissue on the roof of the mouth is like a blanket, right?
Mm-hmm.
And the bone is a surface. Like think of it as a tablecloth.
Okay.
And I'm tunneling underneath there. So it's no longer adherent. It's just hanging down, right?
Yeah. Yeah, like in the old Buicks when you would pull the upholstery off of the ceiling and it would hang down.
Exactly.
Okay, and so what's the purpose of the tunnel? So the tunnel is now giving you access to the bone?
No. So once the maxilla is down fractured, down here, right?
Yeah.
I'm making interdental cuts in between the teeth. Now the maxilla is down. I've tunneled underneath the nasal mucosa, by the way, because you have to do that too. When you go inside the nose, you have to tunnel underneath there, right? Without tearing things up. You don't want all these tears inside there. And now down here, and you have to cut it. You have to complete the interdental cuts. And then you have to cut there. You make a triangle.
Lift up a little higher, lift up a little higher.
Yeah, so you have to make a triangle or an H or whatever you want to do. And take two parallel cuts.
Mm-hmm.
And now you can expand it. Now, and then you have to have a splint which will hold the width.
Mm-hmm.
What is this? So basically you have to have something that is pushing out like this, right?
Right.
So what does that look like? That looks like this.
Mm-hmm.
Okay. Which then would go on the roof of the mouth. Can't see. Let me change the lighting in here.
Yeah, that's okay. The camera usually adjusts. Yeah, the exposure. I think you might have. The sunlight is getting harsher behind you. Yeah. Yeah. There we go.
So this goes in here and holds the width, right?
Mm-hmm.
And there's wires that go through there, and the teeth still touch, but it's holding the width because it's an outward force. And plus you've got. So you're pushing out, you're pulling out because you got screws holding the width, right?
Mm-hmm.
And if there's any question at all, the day that split comes out, if the patient's got braces on, you've got appliances on the upper jaw with slots on them, right?
Mm-hmm.
Slots where a transpalatal arch can go in and hold the width as soon as the splint comes out. As a matter of fact, I have a great case I could show you, and this has to do with why you want to work with good orthodontists. That patient I showed you with the big, huge advancement of the 30 millimeter advancement, her maxilla was paper thin, and it started falling apart in front of me. And the plate wouldn't hold the maxilla. I see the patient the next day and the bite's all jacked up. That's not what you want to see.
No.
No. It's a very uncomfortable feeling. So I said, you're going to go back to Dr. Rose on Monday, and he's going to put in what's called a transpalatal arch, and I'm all set up for this. So there's a slot on the upper molar bands where this rigid arch wire goes in, pops in, and boom.
Like a tent stake. Or like a tent pole.
Pushing it up.
Yeah.
It's pushing it up. And, so we go from a narrow maxilla with an open bite to a closed bite, and the width is, and everything's all hunky-dory.
Wow.
I think I can show you a post-op panorex. You'll see it. You'll see the size of the plates. I'll make sure that the name is on there. If you want to see, you'll see. Yeah, you got to know how to problem solve and think your way and anticipate. Aircraft have at least one safety system for every major system, and often two. So if the hydraulics fail, they can turn cranks, right? An ocean liner can go halfway across the ocean on one engine. You need safety systems, and you need to know how to problem solve. Let me show you this case, by the way. I was trying to illustrate things with examples. This is 5 weeks after surgery. Can you see what this?
Yes.
Yes. It's 5 weeks. You see these huge advancements here?
Massive.
Right? Do you see any screws up here? Nope. That maxilla started falling apart on me. However, she's got a slot, what's called a lingual slot on the first molar bands. Goes to the orthodontist on a Monday morning. I meet her there. I operate on her on a Thursday. She puts that thing in, and we are all good.
It just springs it back open.
Yep.
Wow.
So she was being held out with the outward force from the screws here and here, but this, all this just kind of fell apart on me. That's happened one more time. I probably counted on one hand the amount of revision surgeries I did. I had another patient with a maxilla just fell apart. It's like a potato chip. It just fell apart on me.
Wow.
And, these kind of things happen. So let her heal up. Actually, Dr. Rosie is an orthodontist also.
Mm-hmm. Mm-hmm.
She contacted me years later, and she said, Dr. Bell, I just want to let you know that I got into the Air Force. She graduated summa cum laude from Berkeley.
Wow.
And I said, she contacted me years later, and her recruiter, they need a letter from me because she had hardware in her face. And there's something called an ASVAB, which is the Armed Forces entrance examination. He said, well, I don't know why she's going to the Air Force. She got 100 on her ASVAB. Mm-hmm. And said, well, it's her life dream.
Yeah. Wow. Yeah, that's amazing. And thank you for sharing that case. Last question, doctor, and then we'll wrap up.
Sure.
Could you just describe typical recovery for a patient of yours that's had one of these multi-piece segmental maxillaries and one multi-piece mandibular surgeries? What's that look like?
So a segmental maxillary osteotomy and a 5-piece mandibular osteotomy?
Sure, that's fine. Yeah. Yep.
Okay, so first of all, they get a ketamine infusion in the operating room. I don't know if you know anything about the drug ketamine. Ketamine is an anesthetic drug. It's a dissociative anesthetic, but it also has received FDA approval for the treatment of suicidal depression that's treatment resistant and also for PTSD. It is an extraordinary drug. In the context of trauma therapy or traumatic life experiences, the outcome studies there's a staggering difference between the outcome studies for people that have what's called ketamine-assisted psychotherapy and non-ketamine. So why is that important? Because it dissociates the emotional distress, which is stored as a felt body sense, from the facts of the experience. And one is able to see things clearly. So it has this dissociation between the emotional pain. Physical pain is strongly associated with emotional pain. And it also, as itself, is an extraordinary, like you could literally, the first time I heard about, I was during residency or medical school at LSU, there's a guy trapped underneath a streetcar and they had to amputate his leg in the street. One drug, ketamine, doesn't depress the breathing. It's a total dissociative. It's used for children. So they get a ketamine infusion, which markedly changes the post-operative recovery. That's the first thing. The second thing is, at the beginning of the case, I use a very expensive drug called Exparel. You could look it up. It is a form of bupivacaine, so it basically keeps them numb for 3 days after surgery. But you have to use it at the right time. You have to use it right at the beginning of the case, and you have to time it. There's some technical points. So they're numb for 3 days after the case. They are, as soon as they come out of the operating room, also, I make sure people are really well hydrated, because the more hydrated they are, the less they swell. Paradoxically, if they become dehydrated, if they're fluid depleted, for every liter that you put them in, 2/3 ends up in the tissue, only 1/3 stays inside their veins. So I minimize swelling, minimize tissue trauma, and then they come out and they have something called a helotherm cooling mask, which runs water. It's a very expensive device, but the outcome studies, again, are very, very good. They have that and they go home with it. And then they're not wired shut. So
because of the custom plates.
Yeah, they're not wired shut.
Yeah.
I'll put in elastics usually about 3 or 4 days after surgery. So between the ketamine infusion, the Exparel, the not being wired shut, a lot of times I'll put in what's called Doyle nasal splints. So these are silicone things that go inside the nose, make sure there's airflow inside the nose. They can always mouth breathe anyways. Sometimes people will take a narcotic, like the most I've seen people take is, sometimes people will take narcotic around the clock for 2 days, the first 2 days after surgery, but sometimes hardly anything at all. And then maybe once a day after that. Even then, the first 2 or 3 days are challenging for most people. After about 3 days, that's the maximum swelling. It's pretty smooth sailing after that. And then after that, everyone's recovery is different. I give people 3 months off, because there's a diagnosis code that if you have medical insurance, it's called adjustment disorder. Adjustment disorder means temporary decrease in functioning after a life event. Could be divorce, move, birth of a baby, surgery, whatever. It's a medical diagnosis. You've had a birth of a child, another on the way, moving into a new home. I mean, you have a lot on your plate. So, and you have a good family, your wife's there. Your parents, you said, live down the street, right?
Yeah, that's correct. Yep.
Yeah. What about
Alexis?
Nidra? Alexa. What about her parents?
They live the next town over.
Where do you live, by the way?
Methuen, Massachusetts. It's near Andover, Mass, near Salem, New Hampshire, north of Boston.
Were you born in the Midwest, by the way?
No. Nope. Born right here in Methuen.
I don't know. You have this nice, warm personality.
Like Minnesota nice?
Yeah. Like Winnipeg, Canada nice. That's where I'm from.
Well, it is cold here.
Yeah. Dr. Rose is from Nebraska. Dr. Baum, the other, he's from the Midwest. We're all Midwesterners. And hey, I'm not saying there's nice people not in the coast, but yeah, Midwest nice. You're in Midwest. Yeah.
Yeah.
So that's post-operative recovery. And I want everyone to have a happy ending to the story and achieve their hopes and dreams in life and be happy, healthy, peaceful, and free.
Yeah. Thank you so much, Doctor. I couldn't have thought of a better way to end our conversation other than with those warm, heartfelt wishes. And thank you for 4.5 hours of your time.
Wow.
And,
wow.
Yes. And in particular for your willingness to hear me out about my own health issues and you extended help to me, and I really appreciate that. So thank you very much.
It's an honor. Thank you, my friend. And you call me anytime.